agreeing that the pandemic left a very important footprint, both on health systems but also economies and social life. Priorities have changed, and protecting citizens' health have laid the foundations for creating an ecosystem from people, structures, and services with a common goal to overcome as painlessly as possible the danger of the pandemic. The coalition of the Greek society in dealing with the pandemic has been, and still is very impressive and effective. The USA ambassador, Mr. Payet, also pointed that out. The Greek citizens immediately complied to the guidelines, and no precious time was lost. The best was done. The reflexes of the government were excellent. We all understood that and perceived that in our daily lives. The Minister of Health also underscored that in his yesterday's speech when he corroborated that reforms go on, as well as the implementation of a new primary healthcare system introduction. At this level, I would like to refer to the great feat of the clawback investment with 50 million euros in 2019, which will be pursued in 2020, which was also pointed out by the minister. This is a measure of awarding those who think that they can invest in our country in research, innovation, in both logistics and personnel. This is a very important measure that gives the opportunity to big multinationals to come and invest in Greece. During yesterday's day, we also sought a new development paradigm with the contribution of the health sector, and we heard with great interest the development prospects of silver economy, not only in the field of health and pharmaceuticals, but broadly in the Greek economy through the synergies that can be created with other financial sectors, economic sectors, such as tourism, construction, tourism. We heard about biotechnology, which is proven to be one of the very promising sectors for the improvement of quality of life and the production of financial economic value. We spoke of the contribution of technology in the development and the transformation of health sector. It is true that digital economy and the interconnectivity applications led to impressive applications and demonstrated the need for further digitalization in the field of health. It is necessary to introduce practices that will secure social cohesion, citizens' well-being, and the maintenance of economic activity. The primary healthcare sector were broadly discussed. The speakers, after having mentioned the resilience of the economic system during the first wave of the pandemic, placed the emphasis in developing a network connecting the private sector with the private one and a broader connection between public healthcare services with the region. The goal is the holistic dealing with the chronic diseases, the continuous treatment of the population, the enhancement of public health, and the promotion of health with the contribution and cooperation of all the means, procedures, and structures, be it public, private, or social ones. Ladies and gentlemen, in concluding with this brief introduction, I would like to warmly thank all yesterday's speakers who shared their specialized knowledge and made us wiser. But also, I would like to pass the torch to today's speakers, distinguished speakers from the academia and multinationals. We are certain that this day will also substantially contribute to the production of ideas and formulation of proposals regarding the technological modernization of the hospital infrastructure, in training, medical training, in the assessment, HTA, and the management of the pandemic, and the health expenditure and pharmaceutical expenditure and biotechnology. With these few words, let me wish every success in the works of our conference and a very pleasant and constructive following the day. Thank you. Good morning. We thank the President for the introductory greeting this second day. Let us also thank the sponsors and the communication sponsors of the conference. Let us proceed right away to the first session on the subject of technological modernization of the hospital sector. We'll have the main speech by Mr. Mark Lloyd Davies, who is the Senior Director of Government Affairs and Health Policy of Johnson & Johnson Medical Devices. The title is Value-Based Procurement and Value-Based Agreements as a Key Enabler of Value-Based Healthcare. Following his main speech, we will have an interesting panel that will be moderated by Mr. Kartapanis. Let us all come in tune so as to start.
Together in person. Firstly, I'd like to thank the conveners of the HealthWorld conference and the American Hellenic Chamber of Commerce for putting on this event and also for inviting me. It's a true privilege to be here, and I'm delighted to join you all today. Today, I would like to just introduce myself and briefly Johnson & Johnson, but then really get into a particular topic which I believe is going to add true value and true innovation to healthcare systems all around the world, including Greece, of course. And particularly, I think, in this digital world that we are increasingly living in, where more and more data is coming available. And the COVID-19 pandemic is showing how critical that data is. Data is going to be key to playing a role within this topic I'm going to discuss on value-based procurement and value-based agreements. But firstly, to introduce myself, my name is Mark Lloyd Davis. I'm from the UK originally, currently located in Belgium, and I work across Europe, Middle East and Africa with ministries of health, governments, regulators, and healthcare system leaders, like many of those you have been meeting throughout this panel, on looking at ways of how to really get a win-win for society, for the patients we serve, for the health systems we serve, and also for innovation in driving and making that difference. As you probably know, Johnson & Johnson is a very large healthcare company, very broadly based and working in pharmaceuticals, medical devices and consumer healthcare, 140,000 employees around the world, 260 different operating companies, and active in 175 different countries, including Greece, of course. And it's a pleasure to be here today. So, as I launch into the world of value-based healthcare, if you like, as I was contemplating on this, I've heard yesterday when I joined parts of the conference and today that value-based healthcare, it's a very complex universe in many ways, where you hear lots of different terms being used quite loosely and interchangeably: value-based agreements, value-based contracting, value-based procurement, patient-reported outcomes, real-world evidence, etc., and so on. And I think, firstly, it's important to try and get our terminology correct. When we talk about value-based healthcare, what within the universe of value-based healthcare are we actually talking about and addressing? And secondly, to realize that all of these terms which are used, pricing, contracting, evidence, etc., they do all interact and collide with each other. But what they are trying to do most of all is generate value for the patient, value for the healthcare system, and value for the government. And aligning and agreeing upfront what is value to you is really, really important. And I often find when industry is engaging with healthcare systems, or when governments are engaging with their own healthcare systems, there isn't actually that upfront conversation about what is the value we're seeking to get here. Everyone assumes that they understand the other person's definition of value. And I think it's really helpful to get that on the table and to line about that upfront early on. So if we move to the next slide, I would like to really illustrate an example of value-based procurement and value-based agreements. So in that universe of value-based healthcare, these are the two topics I'm going to talk about: value-based procurement and value-based agreements. And I'm going to use an example of something which is very common, which I think many of us are very aware of, and that's surgical site infections. Now, one interesting thing about surgical site infections is, unfortunately, they're very, very common. But also, it's interesting as you think about the current pandemic we're in of a virus, which is causing huge health and economic upheaval. People for decades were saying a virus could come and it could create a pandemic like this. And on the whole, nobody was fully prepared to the extent they should have been for this pandemic. It was always like, this will be a problem that somebody else will have to deal with later down the line. The other voice equally raised for some years now, and increasingly, is of course about antibiotic resistance. And this directly plays into surgical site infections. So I'm going to talk about this example of surgical site infections with antibiotics working today. But imagine if we reach a time when they're not working, these costs and these health outcome issues will be exacerbated even more than the figures I'm going to give you right now today. So the surgical site infections across Europe costing approximately 19 billion euros. Patient outcomes are not poor in terms of either mortality rates and readmission rates. And of course, the majority of surgical site infections are easily preventable. And I'm going to talk about a piece of technology that can help just play its role in dramatically reducing surgical site infections. And that is a technology in suturing, which is triclosone-coated sutures, which the World Health Organization itself has said plays a key role in reducing the risk of surgical site infections, independent of the type of surgery that takes place. Now, why am I citing this particular example? It's a good specific example of where a value-based procurement and agreement approach can make a big difference for a hospital, not only for the costs of that hospital and in surgery, but also for the patients that are treated. So why is that the difference? Where does that exist? Well, typically most sutures are not triclosone coated within surgery. So most hospitals will procure them, and they are at a lower and cheaper price than triclosone coated sutures. If indeed in the procurement approach, which most hospitals do around the world, day in, day out, going for the lowest price approach and procuring a lowest price suture, you have a higher rate of surgical site infections. What happens elsewhere within your healthcare system is either costs going up as patients are readmitted, patient outcomes figures being poorer as patients are being readmitted, potentially issues of mortality or other comorbidities, or longer recovery time and longer time back into work. And these are costs and implications which aren't tracked by the procuring bodies, because what they are tracking is just the one thing, and that is the fact they procured the lower price suture and therefore mission accomplished. However, by procuring triclosone coated sutures, the chances of surgical site infections dramatically reduce. Savings per operation are on average $185 per procedure, which in the wider healthcare economy of that hospital, let alone the better patient outcomes and better productivity of the patients, is far higher and far better. So it's a neat, small example where by sitting down with your customer within the hospital, by sitting down, understanding what does value mean to them, how this can drive efficiency within the procurement process. I was listening to Professor Alton from Harvard Medical School yesterday, and it's very interesting to him. It met a number of things he said, but one of them, how medical school training hasn't changed for decades, yet we have all this amazing innovation and all this amazing technology. And I would say exactly the same thing when it comes to procurement within the hospital setting and within financial planning. That essentially the training is about how can we control costs by going for lowest cost. In some ways, as the British would say, penny wise but pound foolish. And it's very, very important to think about how can these procurement directors think more strategically with their healthcare system, that by procuring something which may not be lowest cost, they are actually finding efficiency to be driven elsewhere within the healthcare system, as well as, of course, better patient outcomes. If we move on to the final slide. So in this example, what have been our key learnings about value-based agreements? The first learning here was there needed to be an agreement with our customers, with senior clinicians, with the chief finance officer of the hospital and procurement, that surgical site infections do have an impact on the costs of that hospital system, and of course on the reported outcomes by patients themselves. That we need to design a product where we're not thinking, and this is a pressure point in industry where industry has to be far better, we're not thinking about a product with cooler features and benefits, or that much more slicker and shinier than previous ones, but a product that actually really brings value to the healthcare economy. And that value needs to be beyond the patient outcome, is looking at the healthcare system and is looking at the benefits to society as a whole. But really critically, we need to generate evidence. So this is on industry, generate evidence to demonstrate the value that that technology brings to the patient, to the wider healthcare system. Now, we have the new medical device regulation coming in next year now, and this will generate a lot more data, which is going to be really, really helpful. So we should be scrutinizing ourselves and scrutinizing industry, saying, with this new data you have, how are you demonstrating the value you're bringing to the healthcare system and to my patients and to my hospital beyond the product features and benefits in itself? And how can we measure current levels? How can we quantify costs? How do we look at things differently? It needs really creative thinking. And with all the digital innovation coming along, data is going to be key. So we also need to start working with governments about what will be the new regulatory framework to access digital and data. Again, going back to Professor Alton's point, how, instead of thinking about hospitals being buildings and places, how can we think about regulatory frameworks of innovation and data? So there's virtual interaction and virtual understanding. And what I would say, and I'll just close up now as I'm coming up to time, is that there really needs to be a real shift in mindset on the industry side, by the way, and I will completely hands up there say that, but also in all the actors and stakeholders within modernizing healthcare for the 21st century, and understand, and this is just a value-based procurement and value-based agreement example I'm giving, and there are many other areas of that universe which we don't have time to explore today, but understanding from a buyer and supplier perspective, what is at stake, what is available. I mean, inventory control and efficiency, this is another area, but that can be a separate discussion. And health systems need to think, how best do we incentivize patient outcome improvements and long-term efficiencies? Many healthcare systems, and particularly the COVID pandemic, it's about how do I deal with the urgent issue in front of me today, and I just got to get through the day to deal with that. How can we rethink how we structure our health systems, train our staff, use the latest technology, so we're actually thinking for the medium to long term? And I think we all need help with that, including the governments that ultimately fund the majority of our health systems. So thank you very much for your time. I wish I could be there with you in person, and I'm delighted to join the panel now, and I'm sure you will hear many wise words from my colleagues I'll be joining right now. So thank you very much.
Thank you, Mr. Lloyd. Να έρθουμε τώρα στα...
And now, let us come to the Greek speakers, to the panelists. This is a major issue that we're discussing here. Unfortunately, there's a technical problem, and the sound comes and goes. There's interruption in the speech. Well, there are problems with technology, especially with such kind of connections. Anyway, I reiterate what I said in the beginning. But unfortunately, we've got the same problems of intermittent sound flow. I was saying that technology is very important in the field of health, closely linked with the huge leaps of the last years, and we are dependent on technology for many years that were inconceivable some years ago. Mr. Papaioannou, who is deputy professor, who is substitute professor of biomedical technology, will speak on the matter. Thank you, moderator, Mr. Moderator, and thank you for the very honorary invitation to participate in this interesting conference. I only wish it were live. So let us start with my slides. I will be very brief and to the point, and I will express some thoughts and points that I believe that are important for the technological modernization of hospitals. The next slide, let me start and conclude with a piece of information. Medical technology worldwide has been incremental, which in our days will be more than 5%, at a more than 5% growth rate. Therefore, the tools and the innovations available continuously increase each year. Modernization is not merely a renewal or upgrading of medical devices, but we should have a holistic approach because modernization is needed also for in the infrastructure, that is the buildings, hospital buildings, further education and lifelong learning of the medical personnel, even the operation of a hospital per se. Madam Kuklanidou will explain later how many things had to change in their daily lives of hospitals, either now due to the COVID-19 pandemic or other extraordinary conditions. So we modernize the way we communicate, and of course our disposables, our material used, and information systems contribute in this modernization. And more specifically, I refer to those information systems already existing in hospitals, handling the whole medical equipment through its life cycle, from the beginning to the end. Of course, there's no sense speaking of modernization without a measurable result. So we should have in mind that whatever we do should be assessed and should be aiming at a calculable result, either qualitative or quantitative measurements that we should have. Let me indicatively show that Greece, as far as equipment is concerned, is not lagging behind. I gave you, for instance, the XT machines, where we see that we have quite a number of machines, quantitatively speaking, at equal pace and quality of Denmark, Italy, or Denmark. Of course, the fact that we do have technology and we continuously modernize it doesn't mean that we also use it. Here's the great paradox. Although we stably have quite a number of imaging machines, from 12 to 27, it's the unique country that has reduced their use. So there are a lot of other parameters and factors. It's not only the will of a hospital to modernize its technology. There are a lot of other things that affect its use that may gradually lead to the obsolescence and I would like to explain why we use all the less those imaging techniques. It could be an abuse that we do. It could be the bad maintenance or non-operability of those machines or many other reasons. Let us proceed. Therefore, a central role, if we want to modernize something, to my view, that would be the biotechnology machinery, which are not sufficiently staffed so as to undertake this avalanche of new technologies. Of course, if we don't have make a stock taking of what we have, we don't know what we have. We still speak of a registry of medical technology which doesn't exist. And if there's a recording in digital way in hospitals, so as to be able, through an available information system, to know precisely, as we should have the electronic file of a patient that keeps track of a patient's treatment. Similarly, we should have for each piece of machinery such an electronic file on the maintenance tools, its repairs, its overall situation. Without financial resource, of course, there's not much that can be done. And in Greece, unfortunately, we operate more or less on an ad hoc basis and on the personal initiative of physicians, of heads of clinics, and sponsors. And thus, we try to fill in gaps, not in an organized way. Finally, let me say that money is not everything. Here you see the American paradox. Although, so Greece is not really lagging behind with regard to the cost investment ratio, with regard to the overall life expectancy. At the end of the day, we should have something measurable to modernize, but at the end of the day, the quality of life of patients and employees and life expectancy is extended. To the contrary, the USA, although it spends heavily, it seems that this has still not been translated into a longevity and prolongation of life expectancy. Therefore, we conclude that, as I started, we should both at level of policy and administration and economy, we should think that this modernization is a sine qua non, is unavoidable. If we see the European Patent Office, the 10 most important fields with more patents deposited, medicine and biotechnology is a second rank. The first is IT applications, also related to medicine. Therefore, each year we see all the more innovations and solutions, and it is up to us to integrate them, not formally, but actually use them and maintain them at a good condition. I warmly thank you. Thank you, Mr. Papaioannou. All that data has been very interesting. You pointed out that Greece doesn't lack modern technology. Its use, perhaps, is not the desired one. Perhaps in the past we exaggerated. There are statistics on the matter. Now, perhaps we make a more reasonable use of that technology, but still, unfortunately, the moderator, Mr. Kartapanis, is always on an intermittent sound floor. The next speaker will be Mr. Dimitris Nikas, who is member of the Medical Technology Equipment Committee of the Hellenic American Chamber of Commerce.
Thank you very much, Mr. Katapanis, and I would like to thank the conveners for this invitation. Medtronics is a global player. We have 65 areas and sectors we have activities in, starting with minimal verse and going down to imaging and robotics. We have more than 1 million patients that are remotely followed, both for diabetes and for other diseases, the cardiovascular diseases in particular. In the 6 minutes that I have at my disposal, I will speak about value-based healthcare and about how technology can help us in cases in crisis like the one we had with COVID-19. The challenges ahead of us are the aging of population, an increase in chronic diseases. We have a traditional way of dealing with compensation for new technologies. We have slow-moving health policies and regulatory frameworks that affect innovation, and which leads to delays in the introduction of innovation to Greek hospitals. This increased cost for similar systems is a worldwide phenomenon, and sometimes makes governments decide on the basis of an equal distribution of resources. It will be either education or health, depending on where the biggest need lies. Sometimes, even within a country, systems are different in terms of their results for patients. In the Netherlands, for instance, the health system is very well organized. However, for prostate cancer surgery and for further surgical complications, we have 9 times higher rates outside the capital. In other cases, in the automobile industry, for instance, these divergences, these discrepancies between the different centers are not the case. This is something we should consider. Technology is very promising, and the results are supported by data. This has to change. We have to see the results first. That on a value-based basis, we have to speak about value-based healthcare, as the first speaker said. In Greece, we've made a study, and we've seen how this can work. We have to have 3 stages. First of all, we have to choose the disease and the group of patients that will be followed. Then we have to define the parameters. What are we going to measure? Time and results. And all around that, we have to build a model that will be based on the risk sharing agreement as regards the outcome of patients. In many types of treatment, we can be paid like that, be paid on the basis of value and not of cost. In recent years, cost has always been the main criterion for procurement in hospitals and other health centers, and this was not helpful for patients. We had the horizontal systems. Another thing, how can we, as the industry, help the health system manage patients in cases like the one we have now with COVID-19? When we have crisis like this, patients have to stay away from hospitals. How can we follow up our patients without having them come to the hospital? We can use digital technology, hardware. We can have surgery support remotely. we can have patients coming less often to the hospital. And when we have a COVID-19 patient, we should have a monitoring before and after surgery. In all those cases, technology can provide solutions to the health systems of the various countries. During this crisis, we saw that many patients avoided having a surgery. Of course, COVID-19 was something unknown to us. We couldn't put an extra burden to hospitals with surgeries. Now we know what has been happening. In the immediate future, we have to continue treating patients in our hospitals. We shouldn't exclude them from the health system. And that's why I think that we, as a medical devices industry, can offer solutions, because we do have solutions. And we will be able, in this way, to be more effective than we've been until now. That's all on my part. Thank you very much for your time. I wish we can have some time for a discussion later on, and maybe solve some questions from people following this session.
I point out two things from your speech. Indeed, the selection of a piece of machinery, of equipment in the medical sector must be based on the value it offers and not the cost for its acquisition, because cost is paid once, but its value and the contribution to the life of patients may be ongoing. And the second point, as you said, yes, the pandemic has been a great concern, taking the example of the first quarter, but medical problems that patients have not avoided to deal with, which were minor, and avoided hospital at the time. Today they may be grave, and perhaps valuable time has been wasted. So we must find the appropriate solution so as to both deal with the pandemic, but also not leave other diseases, patients with other diseases behind. Have them away from hospitals. They should also be treated accordingly. I don't know whether Mr. Apostolopoulos, who is the governor of the Attikon Hospital, can talk to us now, giving the viewpoint of the public hospital. Mr. Apostolopoulos? Let me thank you warmly, the organizing committee, for the invitation, as well as the chairman of the conference. And let me underscore the high prestige of this conference that has gained a very high position, the decision-making process and the documentation of the medical sciences, health sciences. Let me start by saying that the main challenges of health systems is the upgrading of the quality and the services rendered, both the services rendered, but also the measurement of the output of those services. Therefore, access is an important point for the assessment of all the health systems. A rationalization of expenditure for the medical services offered, the upgrading of the quality of services rendered, the assessment of the efficiency and effectiveness of modern technology used in the medical sector, which is the first stage of the technological modernization of a health system. In nowadays, this is also common knowledge that technology is the main tool of medical science, and goes hand in hand in the future, where in a complementary way we'll deal with the disease. Two of the more important operative elements of a health system, and in extenso in the field mentioned in a modern hospital, is technology, as it is depicted and presented by medicine, telemedicine, information, IT systems, robotics, and other applications, and health policies. The role of technology, especially in hospitals, is extremely important, since through this we can attain goals such as high quality services, health services rendered, the improvement of hospitalization and hospitalization period and attendance, cost reduction, and valuable tools for the decision-making process. On the term of rational technological modernization in hospitals, it mainly has with IT systems and medical technology, and at a second degree with medical technology and infrastructure. Current reality in Greece in hospitals is affected by the 10-year economy downturn that had as a direct result the lack of funds for investment in new technologies. Technological developments are rapid, and technology investments are characterized by distortions and ailments of years. We have seen from our experience to date that public sector has slower rates of adjustment to similar investments, and private sector is far more freer in decision-making process and installation of a very costly, high caliber, state-of-the-art technology. The sub-staffing of specialized departments, the lack of ongoing training and specialization of personnel in new technologies, the existence of obsolete IT systems in hospitals, the full lack of integrated IT systems, along with bureaucracy, have led to a model of modernization that is affected without strategic planning and programming, depending on irrelevant criteria, irrelevant to the pursued output and the overall benefit to the patient. It is given that in hospitals, technological modernization is a very slow process and therefore leads to a great extent to the use of equipment that may be 20 years old with serious problems in operation, maintenance, but also in the depiction of clinical results. Therefore, in this framework, and while financial data of the country were to be stabilized, the the outburst of the pandemic brought about a new ailment. This demonstrated even in a more harsh way the deficiencies and the necessity for modernization, which was partly attained through great donations, but at the same time, it is obvious that the whole structure of health system must change, and especially in the management and distribution of the costly and greatly developed technology. Technological modernization cannot be perceived but as an ongoing process which must be applied in the overall general strategy so as to bring about the desired effects. Starting from the existing equipment, and in order to be able to assess the effectiveness and the efficiency, must be a detailed stock taking should take place. Unfortunately, very few hospitals have such a cadastre, and even those that have, they do not have a system of the analytic assessment of the indices. The recording and systematic monitoring of the equipment will lead to an obvious saving of capital and more rational use of equipment in the development of new measurement indices, the continuous and ongoing stock taking for appropriate interventions. There will be a reliable vigilance monitoring program created. We will be given the possibility to make a new plan on the basis of objective data and facts. We will be able to assess a costly, interesting maintenance or not, the purchase of spare parts or, to the contrary, the need for purchase of a new equipment and so forth. All this will offer easier and more economic decision-making process paradigms in relation to the ultimate output we will have. It is obvious that all this will be very powerful tools for the state and the administration of hospitals in order to co-shape an integrated policy to create operational plans that will aim at specific indices and the pursuit of specialized and very qualitative results. This whole process, which will give us the possibility to put more rational tools in the decision-making process, will only be attained through the contribution of technology and monitoring the developments. The program of substitution of machinery must come from the cooperation of the specialists through the specialized physicians that know the clinical needs and support the operation of that machinery, but also the administration of hospitals that are harmonized with the national health policy based on fiscal and socioeconomic criteria. This cooperation through well-documented studies on the data of biostatistics, on real clinical needs and economic analysis will lead to the best choices for the modernization of the technological infrastructure. The procurement processes must also be modernized and rationalized through the total quality systems. The example, the experience that we witnessed through COVID, and now that we enter again in the management of a second wave, has proven very eloquently that the choice and the decision-making process must be in a flash. And we must satisfy needs and go against bureaucracy. There must also be more effective absorption of the funds, the community funds, and the pursuit of alternative fund sources, sponsorships, and so forth. A to Z is the piece of information and its management. Therefore, the implementation of integrated IT systems that we will manage data not only of the equipment, but also its output, such as the e-file of a patient that is absolutely necessary for a modern hospital. Human resources, staffing with specialized people in both medical and technological domain is necessary for the change of mentality and the introduction of innovative technologies. We see that the latest generation of recruited personnel, medical personnel, is fully aligned to this direction. So investments must also be made in the ongoing training of personnel and issues of new technologies use. The element that must definitely have in the foreground is the upgrading of the biomedical technology with sufficient staffing both in numbers and specialization of the various biotechnological departments, IT systems, whole total quality systems, and so forth. At the same time, it is necessary to have hospitals independent in the issues of technology. The departments of biotechnology can be the key in the rational technological modernization hospitals through, of course, the necessary introduction, the adoption of the necessary institutional rules. The main criteria should also be, of course, the safety of the patient and the best outcome. Having in mind the technological developments and the environment that a health region is active, the economic solutions, and always bear in mind that we also have the information society around us. Most citizens. Could you please be brief, Mr. Apostolopoulos? You have exceeded the time allocated. Yes, Mr. Kartapanis, I will do so, says Mr. Apostolopoulos. Well, most citizens are better informed, so when they are patients and come in contact with the hospital and its personnel are far more demanding. This is an issue and a challenge that must be taken into consideration. And the financial data will be greatly affecting the decision-making process. Thank you.
Thank you very much, Mr. Apostolopoulos, for giving us a comprehensive picture of the situation in public hospitals, the upgrading of technological equipment, and all the parameters linked to that. And now we have Mrs. Kotanidou, who is at the forefront of this pandemic. She's a professor of pneumology in the ICU units. I was following another conference on another issue, on another sector, and I've learned that robots have started replacing humans. This was science fiction in the past. Now we've seen this in real life. It is going to happen with doctors as well. Maybe it looks like science fiction today, but what will happen in the future? Mrs. Kotanidou, good afternoon. Thank you very much for your invitation. That's an interesting proposal, replacing doctors with robots. No, I'm not talking about today, maybe in the future. Well, this morning I heard that robots replaced the employees in supermarkets. So maybe this is the future. Right now, we all know that ICU units are also those units that are most equipped and with high-end technology. They have to be constantly upgraded, however. Unfortunately, in our country, we had this 10-year crisis, and this led to delays in the upgrading of medical devices and equipment. We have medical devices that are more than 20 years old. As you realize, these devices are outdated if we take into consideration how fast technology is evolving nowadays. It's different to work with a modern device than when you work with an outdated one. We all know that surgeries are an important part of a good health system. If surgical departments are not well equipped, we can't have good results either in a private neither in a private nor in a public hospital. So we need state-of-the-art technology both for ICU and for the operation rooms. All of the previous speakers know very well that if the whole system of a hospital is not well organized, we won't have the results we've been seeking for so many years now. For us, it is of utmost importance to upgrade our hospitals, have new devices, new equipment, better training and retraining of our staff, medical staff and nurses, and other people working in the hospitals. Because knowledge is evolving, we have to train ourselves all the time. Otherwise, we are not up to date. Our knowledge is outdated and is worth nothing at the end of the day. So we need a close partnership between the public and private sector. Without this partnership, we don't stand a chance to have the results we are seeking for public health. I wouldn't like to tie you with more issues regarding ICUs. Medical devices are a must for us. It's the most important thing, the top priority. Modern equipment, modern devices, digital systems, monitoring systems. These are very important, especially for follow-up after a person leaves the ICU. These are issues that are being discussed right now at the Ministry of Health. But we need to find the way. We need to find the money for these systems. Without them, we won't be able to move forward. Thank you very much. Thank you very much, Mrs. Contanido. You raised an important issue, the public-private sector partnerships, an issue that is very problematic in Greece. In Greece, these two sectors are competitive to each other. They are not complementary to each other. And really, Greek citizens do need the benefits from such partnerships. Any questions from the audience? I can see Mrs. Madouvalou from the Athens News Center. I can't see any question. Thank you very much for your interesting interventions and good luck with this conference. Thank you.
It just came in mind. I have a question. I apologize. A question addressed to Madam Kotanidou, which unfortunately was offline and we cannot transmit. Answer. Thanks to the excellent education of the medical and technological personnel, we can overcome this problem of the obsolete machinery and equipment. There is no danger that is whatsoever for the life of patients. But perhaps if we had the newer machinery and equipment of state-of-the-art technology, we might be able to have a quicker result, either diagnostic result or whatever. There is no doubt that it is extremely important for us to have the renewal, the modernization of the whole equipment, especially for the IC units. Well, this is positive. I don't see any other query on the screen. Can I say something? Can I make a comment? Without being an expert, of course, says Mr. Nikas. Mr. Nikas, yes, please go ahead. Well, modern technology equipment reduces the time of attendance, of wait, and therefore it increases the capacity of a system. And this is extremely important now that we have exacerbated conditions due to the pandemic. So this is important. So I thank you all once again, says the moderator. I believe that we can call it a session. Thank you. Welcome back. Let us go to the third session of this day on the title Education in Medicine, Medical Faculty and Medical Care. The moderator will be Mr. Ioannis Boletis, who is Professor of Rhinology and Pathology in the Medical School Faculty of Medicine of the Athens University. Thank you, Chairman. Thank you. We thank the Hellenic American Chamber of Commerce for hosting such an important discussion, as it usually organizes with excellent speakers. It's a great honor for me that I moderate such a panel of such speakers who are both renowned, but as you will also realize, you will see their important role. The first speaker will be Mr. Philippou, who is a substitute professor in the Faculty of Medicine, head of the Rheumatology and Clinical Immunology Department in the University of Attikon. And he is also chairman of the Hellenic Organization for Drugs. Mr. Philippou takes the floor. Thank you for the honor and the happiness to invite me that I have to be invited in this panel. This is a very important session, and because it combines research and education in the title. Taking the opportunity due to the unprecedented crisis that the global community experiences, I will make a brief introduction in order to give some food of thought, convey, if you like, my thoughts on how the landscape radically changes at this difficult time in the field of research and education. Let me start with my presentation. May I have the slides, please? Just waiting for the technical staff to upload the slides of Mr. Philippou. What we have seen through international studies and also our experience is that during that brief period that we have experiencing this unprecedented health crisis, we saw a leap made in the introduction of technology and medical services, technology services in the field of medicine, research and education. Let me convey my thoughts on how this very violent and quick introduction and integration of those technologies radically shifts the paradigm and creates a new environment. This global crisis brought about an acceleration of the introduction of state-of-the-art technologies in the medical field. Therefore, having the health at the center, as shaped in the COVID period, we see transformations taking place with regard to the interactions of the health suppliers, the pharma industry, clinical research, policy, and health policies, the financial situation and economic activity at the global scale, and all this create a brand new landscape that offers new opportunities, but also bears some new dangers. Electronic tools have become of broader use, both at social level as well as the level of health and education that the interests of us. We see, therefore, that telemedicine is now rapidly developing, covering many fields. There's also data analysis and concentration of big volumes of data. New innovative programs are used which will promote health in areas and conditions and regions which are not easily accessible. And all this create a new landscape, and we will see how all that interacts in the field of health, but also in the fields of research and education. Physicians who are the monitoring force of the medical services at the level of interaction with patients, are those who have integrated in their daily clinical practice these new technologies. And therefore, while in the past that might sound a sci-fi, currently we see that all the more physicians, all the more hospitals use those electronic tools in order to have an interface interaction with their patients, but also do a telediagnosis or teleexamination. At the same time, this may also, there are also dangers lurking. At the same time, through the digitalization of health, there are huge data banks created which may help in making the right decisions based on a huge data volume, improving at the same time research and, in extenso, education, because the latter are interrelated. Research and education are interrelated and therefore codependent. Problems, however, arise due to those interactions between the health personnel and the patients. I would not tell you that is another field of interest, but in order not to abuse the time allocated, because I consider that the discussion that is to follow is far more important, let me move right ahead and research how this is shaped in the COVID and post-COVID era. What we also, even those who are not specialists, through the mass media, we saw that there is now a huge synergy at the level of pharmaceutical industry, of research institutes, even at the level of states and state institutions in correlation and interdependence with the industry. The common goal is to enhance efforts and move swiftly into solutions. This creates a new mentality, a new way of thinking, which must be pursued in the future as well. This is something positive. The same applies in the medical industry, that is medical technology industry. For instance, in a couple of weeks, we've had the opportunity to create diagnostic tests of retroviruses or you name it, in order to have a quick test. We see, therefore, that scientific community is in an increased interaction and there's a rapid dissemination of knowledge, and at the same time, a far closer synergy between scientific centers. All that, when applied at a national level, but also at the level of broader federation, let me say, such as the European Union, we see that those processes have a tendency to be simplified, and this in the future may operate as a catalyst, enhancing research and innovation. The state and politicians are in close interaction with science. It uses and it is based on science for a decision-making process, and at the same time, it enhances through an economic and active role in boosting research. This we will see in the future as well. We will see states in closer cooperation with the academia and the research community, even if they didn't have such a tradition in the past, in order to have quick and good results in the field of medicine. The main thing, however, which also concerns our country, is the change of social behavior and convictions. When in the past, basic research and clinical trials was something remote, now it has entered into our daily lives. The people understood what is basic research and clinical trials. And I consider that this change of mentality, the change of attitude, and the comprehension of those aspects of science will play a catalytic role in the evolution of education and research in the medical field. There are three main fields of research that promote research. It's AI, basic research, and the decisive role it has and will be having in the future, the clinical trials. Now, what happens with medical education? It has dramatically changed. While we had a phenomenon that we have already discussed, that is having lectures in aula and so forth, now universities are empty. Education became graceless, but takes place through a screen. We have now new electronic tools of advanced technology, communication technology, that offer astounding opportunities. Nevertheless, I would like to make a distinguish it from medical education. We have the pre-grad, post-grad, and ongoing education through conferences and so forth. In some of those fields, the implementation of the electronic tools and the virtual, such as virtual conferences, is good. It will facilitate younger scientists to participate even remotely and exchange their views. At the level of basic medical education, however, medical education consists of clinical practice, and diagnosis must start in the clinic, in vivo. At this point, we haven't found the solution as yet, and this is the major challenge we are faced with. For the introduction of new technologies has taken place in a very quick way, and there we must find a way so as for young scientists not to be trained solely on the screen. It is of vital and decisive importance to have an in vivo contact with the patient. Now, trying to put in a nutshell what are the ways through which science and education will be promoted, which is the subject of this session, and focusing purely on this field, that is, of education and research, I consider at the level of research there should be a cooperation amongst the pharmaceutical companies, a cooperation between the state and the research institutes and organizations of pharmaceutical companies. There should be an adjustment. The sound was cut off, unfortunately. I believe that Mr. Philippou was practically concluding. So let us proceed with the next speech, and perhaps there will be some questions at the end that Mr. Philippou will be able to address. The next speaker is Professor Boubas, Professor of Pathology and Director of the Pathological Clinic in the Attica Hospital. Mr. Boubas has a very rich scientific work. He's additionally head of the Medical Society of Athens and has a well-known contribution in the ongoing medical education. His research work is also extremely well-known amongst his innovative research works in the field of the disease of lupus and as a member of the Academy of Athens. Mr. Boubas, we have the floor.
Thank you very much, Mr. Poletis, for your nice words. And I would also like to thank the conveners of this conference. In the 5 minutes that I have at my disposal, I will try to answer the three questions, the three following questions. What is the relationship between education and research with clinical practice and medical care? Then, what is the meaning of continuous medical training, and what would be the context of and the framework for such a training? And finally, I will try to answer the question of whether research and training are a need or a luxury. And I will explain why. Before starting, let me make some assumptions for the economy of the discussion. because I will use certain terms. Education. It's different training. It's different from education because at the end of training, the trainee is ready to act. When I train my cat to catch a mouse, at the end, my cat should not only know how to catch a mouse, but also be able to catch a mouse. So I need tangible results. When we speak about training in healthcare, this training is supposed to help doctors solve clinical problems with the lowest cost possible and with the lowest side effects for the patients and their families. Then, another assumption. Basic clinical studies are important to improve healthcare. Without basic research, we cannot have applications in healthcare. When electricity and lighting from electricity was discovered, were not discoveries that happened just by chance. There was some research. Infections were not dealt with only after aspirin was discovered. Continuous training is therefore important, and the target of continuous training is to improve patients' outcome and promote health. Continuous medical training should not be confused with the residency. Sometimes, we have things that are ideal for us and things that are wishful. There is a big distance between things that doctors wish and things that doctors would ideally have and things that really happen. Let's speak about education and healthcare first. It's common knowledge that undergraduate medical studies in Europe are not as practical as they should be. These people need knowledge that will be used in their clinical practice and not be shelved with their books. What I think European medical training needs is a more practical approach, a more practice-based approach, a hands-on approach, as it happens in the US. Now, as for residencies, it's a different type of training. The Central Council for Health has made many efforts in the last 20 years to have a homogeneous approach and have some basic access. Nothing has happened so far. And this COVID-19 crisis has put some extra burden on the system. And the training of resident doctors has become ever more difficult. And let me finish with continuous training by saying that it is very important, as I defined it. In other words, doctors are trained in order to be able to improve patients' outcome and promote health in a community. I don't need to give any arguments for that, I suppose. But let's think about this. When we have this changes in the way things happen, which are radical changes amidst a crisis. What can Greece happen with the problems that it has to be up to date and follow the developments? There is a text that is the outcome of a conference on medical issues, which actually speaks about the content of continuous training and the target group of continuous training. Who is supposed to be trained? Who should be responsible for that? And who should certify the possibility for such a training? What should be the certification criteria? Who should finance such training? And then we also have conflict of interest issues that might arise in the context of continuous training. Well, this is a position paper, 3 pages, and you can find that at the website of the Medical Society of Athens, www.mednet.gr. In other words, let me conclude by saying that continuous training, education, and medical practice are interrelated. They cannot exist without each component cannot exist without the others. We have to have a framework which is equal and equivalent to international models and standards, and takes into account experience from our country. Finally, let me finish by saying that both medical training and research, which are based on the international rules, are a key, something that all European countries have. We cannot speak of ourselves as a European country if we don't have medical training and mainly research, basic research, preclinical research, and clinical research. Thank you very much. Thank you very much, Mr. Boubas. You were very clear in raising the various issues that this discussion has to touch upon and deal with. And now let's move on with Professor Emeritus Mr. Prousos, who is well known from his books, from his publications. All the medical world of Greece knows him very well, and he's recently become a vice president of the highest council of the Hellenic Independent Authority of Higher Education. Those of us who walk in the clouds have high expectations of you, and I'm saying that we are working in the clouds because in the past we've always had hopes about similar things and nothing happened. But now maybe something else will happen with you.
I'm certain that there will definitely be great progress in medical research and technology, especially biotechnology. The previous speakers were very eloquent. There's no doubt that there's an interconnection and interdependence between biotechnological research, medical education, and public health policy. And all these must go hand in hand. As you all know, Greece has gone through 2 major stresses. One was economy, the economic crisis, starting from 2008 and onwards, and upon that, the pandemic COVID-19 added up. So let me focus on something that must is a sine qua non prerequisite, and this has to do with education, the education of the Greek people at large and the health personnel more specifically. There must be a control of the stress of the health personnel before, during, and after the pandemic. As we know, the psychoeconomic crisis of the pandemic has a huge negative impact on the psychosomatic health of our citizens, of the whole world actually. This has a multiplied impact on those who work in health services, because those are the ones who come first in contact with the disease and remain exposed to it for a prolonged and repeated way. We know that the negative impact of stress concerning both the mental and physical health can be dealt and mitigated or even done away through the appropriate psychological management of the stress. Therefore, by developing assessment structures and stress management mechanisms, this is a necessary prerequisite. We do have the appropriate organizations and agencies that can organize such centers in Greece and the whole region. Those structures will not only offer services to the medical personnel through direct or virtual boosting, but they will also have promote digital literacy in all country. The understanding of the socio-motor and socio-physical impacts is the basis of the so-called cognitive therapy. My personal view, therefore, is that the current crisis of this pandemic will not have solely a negative effect in our country and elsewhere, but will also have some collateral benefits. And the main collateral benefit is, first of all, as the first speaker has mentioned, was the use of technology that was very quickly developed and is being used. And on the other hand, the knowledge of biotechnological research and clinical action. And third, we will understand that education of our citizens is very important, so as for all to understand why we do things such as wearing masks and not having such a huge wave of resistant, that is mask objectors who do not want to vaccinate their children or wear masks. This is an issue of education, which I believe will be accelerated over the next years, precisely because we have gone through these dire straits of the economic crisis and the pandemic crisis. Thank you. We warmly thank Mr. Chrousos, who, along with the other important things that he said, I believe could not ignore the overall discussion about stress, since he is in the international foreground in the field of research and promoting knowledge on stress, not only on the mental health, but also in its interconnection with the body ailments. And I believe that this is the best example of our integrated Hippocrates medicine, which we are proud of. Whoever want to have a food for thought and a pleasant trigger, Kathimerini newspaper has presented articles of the professor in its last two editions, and there will be a third one following. And let us move to another field of the scientific field. We give the floor to Mr. Kyriakos Souliotis, who is Professor of Health Policy and Vice Rector of the University of the Peloponnese. Once I used to call you, Mr. Souliotis, the most eminent of the young generation. Now I would like to call you that, although you still seem very young, you are a bit older. Well, everything changes.
Things change and years go by, and science evolves. Before starting with my intervention, I would like to thank all the participants for their contributions, as well as the organizing committee. You know, Chairman, Mr. Politis, this roundtable is interdisciplinary, and this is how medicine should be treated from now on. We don't have absolute truths or a person who is and absolute truths. And things were not happening like that in the last decade. Let me show you my slides, which explain my thoughts in more depth. As the chairman predicted, allow me to speak about the operation of health services and the health system. Research and education interact with each other and give feedback to each other. We should take stimuli from education in order to raise research questions and vice versa. If you look at the system in Greece right now, patients are number one. Patients and their needs are number one. The main challenge is whether we have some needs that remain uncovered either by the public or the private sector. This is not as important. The most important thing is that we have both public and public and private financing. And there are also some areas where new research products and new educational methods are needed. We have to produce results for our students. We have to analyze the big databases we have at our disposal. There is a fetishism against data, and this deprives us of the possibility to draft policies on the basis of this data. We also have to take into consideration the preferences of citizens, which are not preferences are not a synonym of needs, and sometimes they come first. We also have to measure accessibility. In many surveys, we've realized that some services are supposed to be accessible, but they are not at the end of the day. This is a field we have to go deeper in. And finally, let me speak about the well-known evaluation of medical services, which has to do with everyone. Users are the first, but also we have to look at what the employees in the health system are experiencing, what their views are. Then we also have the financial aspects, pricing of medical services. In recent years, many tools have been developed internationally that we have to acquire as well and use in our discussion. Then we have private insurance, some limits as regards the expenses, for medical expenses that each one of us can afford. And in general, there are many research questions that are available. And if we start with these questions, we will be able to find answers. So we need a well-documented health policy. This is something that I developed together with Mr. Koletis. In order to draft such a policy, you have to see where you stand. Look at some unfortunate top positions that Greece holds. So despite, apart from the qualitative issue, we also have a quantitative issue in Greece. This does not mean that we haven't created an efficient number of health workers and medical staff. We do have people, but maybe these people are not specialized in the right fields. We have to listen to people. We have to look at the market and see what the needs are. This is not bad. We have to produce stuff that will cover our needs. We don't want to produce unemployed people. And of course, we need to have dedicated staff for specific areas which demand more resources. And resources are scarce and sacred. And then we have to look at whether the health system creates inequalities, whether some medical needs remain uncovered. Here we have a top position again. This is very sad. Sometimes the cost of health services is a barrier. We have to find an alternative mechanism to compensate health care. Once again, we have the highest private expenditure for medical issues in Europe. Households are pushed to spend huge amounts of money for medical issues. And what we need is to find more advanced tools to pay for these needs. And then we have new technologies. Greece is not good at absorbing new technologies, and we are at number 10 as regards the quality of health services. So we have to have alternatives to adopt new technologies and evaluate the quality of medical services. And all these things have to be linked to compensation. We cannot have the same, let's say, price for two services that are provided in a different way. Another slide here. We have the issue of the aging of population. In the last decade, we have a double-digit increase in aging. So the demographic problem will be huge in the future. Our country is already problematic. But in the years to come, it will become even more problematic. What does that mean? People will live more years of their lives with health problems than without health problems. You know, the elderly are 30 to 40% of health expenditure, and they are 50% of the population. Now, with the aging of population, these figures will increase even more. The increase in consumption of drugs is higher when people are older than 65 years. And the same goes for medical services. This is a challenge for us. We have to rush into it. We have to run research models in order to train the critical number of medical staff that will deal with this problem. Another survey here for pensioners. Their expenditure for general goods is lower than that for drugs and medical services. So, we can have an analysis of behaviors and risk factors. And this is a huge field of research. Many other people, apart from me, have researched this issue. And this pandemic actually revealed some irrational behaviors that cannot be documented. Nowhere. Here you can see very the fact this survey has shown that well-educated people did not take the message. The less educated people did take the message. So the main issue here is the message. There is very low medical literacy amongst the population. We have to create tools in order to improve this. If we have a better relation with medical services, we will have more compliance and a better functioning of the medical system. So, to sum up, the medical community has to listen to the needs and wishes of patients, to look at the needs and wishes of the market, to exert an influence in the right direction. I'm so happy that Mr. Chrousos is now at this position. We're expecting a lot from you. We heard the announcements about about mood independent universities. Let's see what happens. I think that we need to create flexible educational programs. We have submitted a proposal to the ministry on that. And if you look at our curriculum, we have some research areas and educational areas such as health and safety, international and supranational health policy. All these issues can be investigated. Let's not fool ourselves. This pandemic has changed the way we see things. We need new tools. We have to have global public health, global health approaches. We have to be present. We have to be ready. We shouldn't waste time, as we did with COVID-19, and we have to improve our potential in Greece. In order to do that, we have to be ahead of developments. Thank you very much. Thank you very much, Mr. Souliotis, for explaining your own point of view, which is, let's say, supplementary to what other speakers said. Now, let's go to our last speaker, Mr. Gikas, member of the Medical Devices and Diagnostics Committee of the American Hellenic Chamber of Commerce and General Director of GE Healthcare for Greece and Cyprus. Another voice that we are eager to hear.
Thank you. Good afternoon. Thank you for the invitation and the opportunity to participate in this very interesting roundtable. It's extremely interesting because being the last speaker of this roundtable and with these great proposals I've heard, I can better structure my thoughts from the viewpoint of medical industry. So let us view what it means ongoing education from the viewpoint of technology, when this is a little bit before or after being integrated, just integrated in a health unit. I will agree with Professor Buba that ongoing education is indeed in the ideal sphere of their choices of physicians, something that they seek. Nevertheless, when the time comes and technology is integrated in the health units, there are a series of reasons, as mentioned by Professor Chrousos, that cause this stress. It has to do with the workload, it has to do with the lack of resources, and therefore the implementation of the ongoing education on the new machinery and equipment becomes difficult. On the other hand, Medical technology, I can assure you, invests a lot in on this part, continuously tapping from people and skills on the education on medical devices. The same applies with their platforms. Continuously creates platforms and new tools so as to have immediate access to educational material. It is worth mentioning that in our country, there are a lot of multinationals, and one part of tapping skills is from abroad, where we manage to bring back people, highly skilled people from abroad, precisely in order to serve as tutors on this technology. Therefore, we both import technology, but also we export to the whole of Eastern Europe. During the pandemic, this whole preparation was greatly put under strain. And unless we had this infrastructure, unless we had the people either readily trained and the platforms, it would have been extremely difficult to remain the front line. But we managed because the infrastructure was there, and we managed to be there even in vivo, in the X-ray departments, in clinics, or better through digital platforms where we could educate or consult health professionals. And that was extremely important. What is important is that the industry views education in perhaps different way than some years ago. Now we no longer focus on the device, but on the operator. We know that one of the most important interactions between the device and the pharmaceutical, the difference is that the device needs a very well-trained operator in order to be effective. So the issue of knowledge is predominant. So it's important to focus on the need of the user, of the operator, and jointly expand his skills. Similarly, what we seek is not merely an after-sales service. What we do is precisely offering value to what happens in the daily practice. And this doesn't have to do only with the clinical result, which is predominant, but has to do with all the other aspects of medical technology. In other words, how can health professionals improve their use and better integrate it in their daily lives, in the health system? How the device can become more productive, more effective, for instance, more functional. How can they build better protocols in X-rays, for instance? How we can limit the exposure to radiation during X-rays? How we can make interventions safer and quicker? All these integral parts of the medical education and must obviously have it ongoing. This education, that is. Something equally interesting, it was demonstrated during the pandemic, is that we are no longer on this education paradigm one-to-one, but we move to other models where either through digital platforms or other ways we can create networks. That is, we bring health professionals closer, and this creates groups and transfer, know-how transfer, which is valuable. Finally, as it was very well said by Mr. Souliotis, we must see this part of assessment here as well. A medical device, during its purchase, we focus on technical characteristics, standards, technical standards, and we forget perhaps that the predominant dimension is how this will be supported with know-how throughout its life cycle. This must be assessed, who will be handling it, how it will be done, and in what capacity, because it is only then that we will have a sustainable development of technology throughout the life cycle of a device. With regard to research, another comment, big companies and ourselves, we invest heavily on research and technology. This is a part that leads us into producing innovation. And the part of research, another integral part of education, especially now that research is based on data, because it supplies data on AI. So we need broad spectrum and excellent quality data. We refer to big data. Such data exists in our country, which is useful and could be tapped. In order to produce, we need very well-trained personnel that must be very well-focused and have priority. So it's for that data to be produced and supply a research. And then in turn, this research will feed the technology research. Thank you, Mr. Gigas. We have 5 minutes at our disposal. I don't know who follow. If there's a question to be addressed by the audience through the network for one addressed to one or more speakers. Whoever from the speakers would like to address a question to any other of the speakers of the roundtable or make a brief remark. Mr. Souliotis, Mr. Gikas. Well, if you allow me, let me say something. Allow me a 1 minute comment from each of you.
All of you have clearly spoken about the relationship between research and education in order to improve our healthcare. Mr. Bubas said that the whole educational process and research should target at training a cat to catch a mouse, but also to have a cat that can catch a mouse. In order for things to go in this direction, we need a regulatory framework, laws, regulatory decisions, recruitment of staff, evaluation of staff. All these things will make our research, our education much better, and will make all of us look for these things in education and research. So, do you think that what we have right now is enough? If yes, why? If no, what can we change? And how can we move in the right direction on a practical level? Mr. Chrysos. Well, we have all the ingredients, and if we improve them, we will get where we want. We have know-how, we have people, we have knowledge. We have all the ingredients, but we don't have the regulatory framework that will finally bring a good result, a harmonious result. I will follow up on what Mr. Souliotis said. We spoke about undergraduate studies, but we can go even further. Curricula are not interdisciplinary enough. I would have liked more interdisciplinary curricula that include public health, promotion of public health, etc. Mr. Philippou, can you hear us? Yes, I can hear you, Professor. I think that the existing situation is good, but it has to go a step further because our society has gone a step further. It's not only an issue of education, it is an issue of general mentality, let's say. We have already heard from previous speakers that education is important as a general value, as a general rule, people have to be educated, then they have to be trained, and then we have to provide them with the tools and the systems that will allow them to adopt the new tools that technology provides us with in the next decade. Thank you, Mr. Shoulotis. Thank you, Chair. We don't need more rules. The more the rules, the more complex the situation becomes. So we have universities and research centers in Greece and abroad that can work together without having to abide by this strict regulatory framework that becomes a barrier. We need to breathe as research institutions. We need to make synergies. We need to cooperate and have the right to move more freely. Mr. Gigas, I will put it in a different way, but it's the same thing. We have to give a well-designed priority to a training-based system. Education is an added value, that's for sure. Okay, this is the end of this session. I would like to thank all the speakers. This topic was very interesting. There is a lot of room for discussion, but we don't have more time, unfortunately. Maybe the American Hellenic Chamber or any other forum could give us the opportunity to discuss about it again. Thank you. Thank you, Mr. Colletis. We are always here for you to host your discussions, not only in person, but also virtually. Thank you, all of you, for your participation in this session. And now let's move on to the next session, which is entitled Evaluation and Prospects as regards the COVID-19 pandemic and its management. We have as a coordinator Mr. Charalabos Gogos, who is a professor of medicine. And then we have Mr. Kontiadis, Mr. Tsouros, Mr. Koumanes, and Mr. Kyriopoulos.
Small delay for technical cooperation. Good afternoon. On behalf of myself as a moderator and the distinguished speakers of this roundtable, I welcome you to the 7th session of the 19th HealthWorld 2020 conference. And this session has the title Assessment and Management Perspectives of the COVID-19 Pandemic. As you know, some 9 months have gone by since the first outbreak of COVID in China, where originally we saw phenomena which were unexpected and non-interpreted. But once we managed to isolate the virus SARS-2, COVID, that has caused this pandemic, that has spread all over the world with huge number of cases, reaching 50 million with 1 million deaths. As you know, the problems are not merely health, but with a lot of extensions, not only health, political, economic, and social extensions and consequences. And the management of this whole complex consequences is a huge issue and regards many specialties and a lot of fields beyond that of medicine. So before proceeding to the issue of the management of the pandemic, the first step is assessment, stock taking, what has happened, what has done till now, what were the errors perhaps, who should be involved from now on, and what is to be done. We have with us distinguished speakers. I will gradually present them. First I will be presenting them each while they will be taking the floor. Mr. Panagiotokopoulos will be substituting Mr. Arkumaneas, and because he had a previous engagement. So if you allow me, because it is a difficult era and obligations in LD are very important, if you excuse me, Mr. Panagiotokopoulos will be the first speaker because he has another engagement in LD. Mr. Panagiotopoulos is a distinguished colleague in the University of Patras. He is a pathologist and has greatly involved in the issue of the pandemic, Vice President of the National Council of LD. We are almost on a daily basis together for management of pandemic, and we are involved on hours every day in order to assess. So with the permission of all the other, I will please ask him to make the first presentation. Yorgos, you have the floor. Thank you, Mr. Gogos, for the kind words and the introduction. I apologize from the audience, but Mr. Arkumaneas is in Mytilene. He tries to face this major humanitarian crisis, and I was asked yesterday to replace him. So I tried to respond and say a couple of words and have this internet interaction. I did not have the time to prepare slides. Of course, with slides, it's the best way not to tell the truth. So I'll just be giving you my personal truth by heart, by improvising, because I'm in Patras. I'm then at the office next door to Mr. Gogos, and I'm coordinated through the middle wall as well. So let us speak of how we witnessed in the National Organization of Public Health the assessment of LD. So I will try to make an instant assessment as follows. When I became Vice President on contagious diseases that had the name Kelpno, my car broke down and took a taxi. I took a taxi and told him, take me to LD. And he asked, what was that? There was no pandemic. That was October of 29. I told him, TLD is former Kelpno. And the taxi driver told me, this is a beehive. Where are you going? This is the leg of the wasps. So I arrived there. But I believe now, following our participation in managing the pandemic, There's no person in Greece, even if they are critics, no one say that this is the lion's den. I believe that this per se is a major feat for the organization and a legacy for the future. So what did AOD do? AOD, as a national organization that is in charge with the role of promoting public health, must always be on epidemiological alertness and be related with the monitoring mechanisms. Due to the globalization, the very frequent transfers and travels, there are monitoring systems which AOD is connected and takes timely information, actually once a week before the pandemic, when we still had time to discuss amongst us. Once a week, we had a discussion every Wednesday with the presence of the very popular Mr. Stjordras, who was in charge to convey the information from the network of abroad if there was any threat. This is how we learned through Mr. Stjordras that there was a problem. That's how we learned about this new coronavirus from Wuhan of China. We were the first to wonder whether this regards that, whether this is a new SARS, a new MERS, what happens and what would happen. It is within the role of AOD to assess data and not only assess it, but also be in continuous bilateral communication with international organizations. And by that we mean the European Center for Disease Control, which is based in Stockholm, and there are also Greeks who speak there, and the WHO, the European Commission, and so forth. And we must always be prepared. We must always be alert. So once we saw that this epidemic most probably comes here, we prepared a plan for dealing with the endemic before the disease, before it became a pandemic. What else we do? We support all the services of the Ministry of Health who are in charge to clarifying the characteristics and the way of transmission. How is it transmitted? Through small droplets with the air condition, with shaking, with kiss, social distance. What way? Now we know all that, but at the time we did not. And we are in charge to explore all that and see how it happens. Because this has to do with what happens. What are the pathways? Something important that AOD did was to define the outbreak. What is the case? What is the case? Someone who coughs a lot, who has fever, someone who has 2 or 3 of the 5 or 6 symptoms, and under what circumstances? This is important because when we define the outbreak, this is related with the testing, with diagnostic control. Now we do have reagents. The beginning we didn't. At the time, we had to make a selection on the basis of some rationale. So defining what is the case was very important for the onset and the evolution. And this definition cannot be copy-paste. Of course, we consult international literature and organizations, but whatever happens must be related with the international reality. And our definition was close, but not identical with that of the ECDC. And this will be discussed. So we do have the recording of the case, which was important. Now, what else? We had the definition of the close contact. What is a close contact? Someone who is next to you at 5 meters, 6 meters, 10 meters. How many? Anglo-Saxons say 6 feet. 6 feet is 2 meters, 1.8. And for which duration? Now, within the air flight, how many are close? All these seem simple, but this is not so. A lot of work was put in order to put things. The breadth and criteria for isolation quarantine. for the patient, even for the asymptomatic carrier that has a positive test. Contacts are to be quarantined. This is not the same, they're similar, but have one regards the outbreak and the other concerns close contact. We also helped the ministry to select the hospitals of reference. Mr. Chiodras went to Atiko. We made simulation in the first days. Mr. Arkumaneas imitated the patient. I was the accompanying person of the president, and Mr. Chiodras was the urgency physician. And it was a real drill. We wanted to see whether the Attikon hospital could sustain. We went to Sotiria. We also went to Agia Varvara of contagious diseases in a half-closed hospital. So we helped the ministry to characterize and determine in the first period the important reference hospitals. Equally important was the lab reference, the reference labs. We started with Pasteur, the one of the medical faculty, and the laboratory of the Thessaloniki medical faculty, and tests were held within a couple of hours. Again, we were criticized about the time period, that it was in 7 or 8 hours and not in 2. At the same time, UK, far richer and stronger and vivid in the global, had only one reference lab, and we had 3. The UK would give a result in 5 days, and we would give it with a couple of hours. A friend of mine, who is a physician in a British football club, and sometime at the beginning of the pandemic, called me and told me, one of our footballer came to Milan, and we made the test. He said the test will have a result in 5 days. Can I send you a test? Do it in the private sector. He told me there was no sector, only in HSS, and after 5 days, we at that time, with 3 reference labs, we had a result within the same day. So the lab and hospital of reference were funded by EOD. We trained the personnel in the use of hygiene measures. Whatever you see now with masks, aprons, donning and doffing, how you do, all this campaign for training the health personnel started from EOD and was pursued by the colleagues, by the committees. It started from us. We had a call center for the audience and the professionals. We received more than 500,000 calls. Of course, when we have 20, 30, or 100 calls that were erroneous within 500,000 calls, it is within the framework of the statistical error. In its vast majority, we managed to satisfy more than 500,000 calls. We have contributed in the repatriation of patients through Wuhan. We had personnel that went to Rome to bring back the first Greek repatriated. Guidelines. EOD is almost coincides with the guides for the patients, for the schools, for the nursing homes, for everyone that have to be updated very often. We can't still have the guides of May when data changes. A large part of our personnel is involved in reviewing guides so as for them to be simple, comprehensible, practical, and easy to apply. Exploration and tracing. Exploration is the mechanism. Why we had this? How did we get the contagion? What has happened? That was the exploring. Tracing of contacts in acknowledging and isolating the close contacts. This has been undertaken by civil protection, but for a big period was done by EOD. Now it's mostly the responsibility of civil protection. Recording cases proceeds. One must record the cases. Originally, it was manually in Excel, and a great effort was made by the Ministry of Health in cooperation with the Ministry of Digital Policy, and we have the renowned National COVID Registry, which is not easy. It was hard to use, but now everybody knows it. Now we have a central registry. We don't have to make phone calls and faxes to cross-check the information. For those who are intubated, it is easy to note. You only have 1 minute, please. Okay, so the addition of the daily report is also the responsibility of AOD. We participate in the risk communication. The central network that is established by AOD, and the most importantly is the assessment of epidemiological characteristic of the pandemic as it evolves so as to depict it in this country, not in America, Poland, or the UK. The pandemic is different in Greece. We have other population, other habits, other genetic characteristics, and other habits. There we will see the big contribution. Furthermore, we did tests. We organized the network with COMI. They have more than 300. These cars with the nice cars that circulate around Greece and take molecular tests in structures, in necessary homes, in vulnerable groups, in ports and gates of entry. COMI is the executive branch of AOD. And what else? We upgraded the central laboratory of public health, which is in Vari, and which was devaluated over the last years. I'm very sad to say that the last years didn't do anything. This lab had excellent personnel. We mobilized processes. You know that the public processes are difficult. Procurements don't happen overnight. We managed to overcome the impediments. We had reagents, and now KEDI conducts 1,000 molecular tests per day. We have made various measurements, more than 2,000, to have also a plasma imaging of the epidemic in Greece. We thank you. AOD definitely has played an important role, the most important, along with the Ministry of Health and the committee we cooperate with very closely. It was a main role, along with the managing role of the civil protection. Perhaps we will have some time in the end for a discussion. Let us move forward to the next speaker, Mr. Xenophon Kondiadis, the professor of public law from the Pantheon University, head of the institution of Themistoklis Tsatsos. Mr. Kondiadis, you have the floor.
Thank you, Chair. I would like to thank the organizing committee for this opportunity to speak in this international conference and to have a discussion, an interdisciplinary discussion about so different issues. I will now make a presentation on something very different from what the representative of AOD so vividly described. Let me speak about the institutional aspects of this approach, and let's speak about the vaccine a little bit. I will speak about the rights, the limitations, the mandatory or non-mandatory nature of the vaccine, and what lies ahead of us. This trust test on the part of citizens that has to do with how the government deals with the crisis is very important. Political decisions are taken in an urgent way because of the urgency of the crisis, but at the same time, we have this distrust on the part of citizens vis-à-vis what politicians say. When Mr. Tsiodras, the scientists speak, people trust them, and the technocrats are not so much heard anymore. They are rather excluded from the management of this crisis. This is the so-called meta-democracy. It is, let's say, a symptom. It is the way we need to deal with similar issues. Is there another way? Somebody could ask. Of course not. The experts have to speak. But when the experts don't agree, what happens? The politicians have to take the floor, and their role is more difficult in such cases. Let me speak about the management of the crisis until now. My view has always been that the main rule we have to follow when we have such a health crisis is the protection of life. Of course, rights have to be limited when the protection of life and health are threatened. At the same time, this pandemic showed another aspect of rights. It's the term, it's the definition, it's duty. It's the duty we have vis-à-vis other people, vis-à-vis our family, vis-à-vis the medical staff. This right to health is the duty of all of us not to get the disease, not to transmit the disease, not to send more cases to the health system. The Council of State actually has deliberated and has issued a decision which says that health is the utmost right. It's above all other rights. So from a legal point of view, the way the measures were taken was absolutely compatible with our Constitution and international law. However, each limitation, each measure has to be judged separately. Now, let's speak about the vaccine. We've been following the developments as regards vaccines, and this pandemic has made this discussion about whether the obligation to get vaccinated is constitutional or not. This discussion has become very important with this pandemic. This is a discussion that had already started in the past with regard to certain pediatric diseases. Now, let's look at this question from the following point of view. We know that a vaccination needs an informed consent because of the side effects that vaccines may have. Of course, it is assumed that the side effects have been made away with during the tests, the clinical tests. But sometimes these things happen. You cannot exclude side effects when a vaccine becomes available to the public. So how can we make the informed consent and the obligation to get vaccinated, how can the two things become compatible? I think that even if the medical community considers that the vaccine is the only way to deal with the crisis, consent is not only affecting the subject of this vaccination, but also has to do with the rights of everybody. Those who will not get vaccinated will actually benefit from the immunity of others. This pandemic, with its particular characteristics, will actually impose a new discussion. We will have to revisit all these terms, all these definitions. Prevention is the heart of every public health system, and it goes together with the principle of proportionality, both constitutional principles. These two things have to be taken into consideration as regards the mandatory nature of vaccination. I'm sure that we will very soon have this publication that will speak about herd immunity and the vaccine and will bring forward the arguments I mentioned. And when this is available, we will also have to see how we will deal with the issue, because there's also the financial impact of the pandemic. For us, in other words, to impose a vaccination, we should not only prove that the vaccine is suitable, we should also say that is indispensable, because suggestions and requests are not enough for some groups of people. When I took the taxi today, I heard that COVID-19 is a conspiracy. I heard that the vaccine will bring some results which are either desirable or undesirable. We have to revisit those perceptions, and LD will have to make vaccination mandatory. That's my point of view. Thank you very much. Thank you very much, Mr. Kontiadis. You raised extremely important issues. For instance, you spoke about a recommendation dash strong recommendation dash mandatory vaccination. Well, this is important. We had to make this choice recently, and we opted for strong recommendations because we didn't want to have a mandatory, let's say, dictum, but this did not have a result. Now, our expectation for the control of the infection are all boil down to a good vaccine. In Greece, we haven't discussed this issue, whether vaccines should be mandatory or not, but this discussion should start at a certain point in time. Now let's move on to our next speaker, Mr. Arose, International Advisor for Diplomacy, Policies and Strategies of Health. Mr. Tsoures, you have the floor.
Thank you. Thank you, Maiten, for the invitation and the honor. I would like to say a couple of words. Already, a lot of us have already met in various roundtables during this last semester. So I would like to try to say something new, to shed some new light. First of all, with regard to assessment, I would like to stress that assessment should be done and in a systematic way when this whole adventure of our country and the whole of the planet will have come to an end. Let me start, however, from somewhere that is most pestering us, and this has to do with the hard story of public health in our country. I heard Mr. Panagiotopoulos telling us what AOD has done, and I was very glad. But there's also another reality in Greece. Greece has a very anemic public health, which has been ignored for years, both at institutional level and human resources and resources at large. So a first question that I would raise would be, was Greece ready to deal with such a situation? No, definitely not. The fact that there has been a very strong political will, the fact that there have been excellent colleagues who all jointly managed within the first period before other countries managed to react, that had far better reaction systems such as the UK or France, who managed to strike a balance to enhance the trust of the citizen at the beginning and put the situation under control so as to leave some time of breath for the system, for the hospitals, for the outpatient centers, so be at the end of the day at a better position so as to deal with eventually more cases. This we managed. But I must remind you that 1 month before the pandemic, the current government legislated or adopted a bill for public health that definitely drags us back for 20 or 30 years back. We could have been far more ready because the whole game in the coronavirus pandemic, especially in the countries that have proven that they can react, is not only on what happens on public level. It is also played at a local level. New Zealand, for instance, which is the best country in its response in the world, the way it responded, and it continues managing this situation, as well as Taiwan, Southern Korea, and some other countries, is that they have this capacity locally. I don't want you to tell me that at the outbreak, the president of AOD and Mr. Childress and Mr. Panagiotopoulos did a simulation in Attiko. This should have been done and reiterated months ago, months before. Do you know what the preparation we had done in 2004 for the Olympic Games? What kind of simulations had taken place? So in the case that would be a terrorist attack or whatever, by that, I mean that we must be very satisfied that the first stage of the pandemic went well, that the system acquired some trust, that a lot of things were done that have helped us to come to a good point. But then we lost. From one point onwards, whether in communication level, be it the controversy of messages, the conspiracy theories always existed. But during the lockdown, no matter how consistent, because there was a consistency in the messages emitted from the state, because figures were still low, there was in a way a broader cooperation. At some point, this was lost. The ball was lost. At some point, we started speaking of personal responsibility, when it was no issue of personal responsibility, what would be done. This is an issue of social consensus. I work a lot in Korea and Taiwan. If you see there is a society in consensus. It doesn't set as a culprit the youth or the retired or who know. There is a feeling that we all care for what happens in our country. There's no one who's more or less, no citizen. They are all on equal footing. This is why I say that when you have the outburst of the pandemic, we must assess the vulnerability. Can we acknowledge who were the vulnerable populations? Let us not speak only of the old people. The real vulnerable may be the pauper, those who live in undermined, in unprivileged areas, those who do not have environment. I was ashamed, for instance, when they asked me where I found myself in the lockdown. Yes, I found myself in Athens and I was shut down, but I had a wonderful time. But there were many people actually who would live under very dire circumstances, not the same as mine. And I speak precisely for those areas, those neighborhoods who they had to come out their house in order to be able to live, to have some revenue or some support. Therefore, today, the big challenge for us is not to forget where we started from. We must invest in public health the same way other countries do, and the way we invest in the defense, for instance. Public health must be high on our public agenda, not remembered solely when there's a crisis. And I also have a complaint. Institutional public health was practically non-existent during the pandemic. AOD had the role as very well and eloquently presented beforehand. Yes, the institutions, however, of public health are many other services in the ministry, in the region, at the local level. Those are the services that are supposed to take the weight of managing a pandemic in the countries that really understand what public health stands for. And I must say something else that my friends may think that I'm too critical. I say public health is not a pandemic. Is not. Why not? The crisis we managed on terms of rules of public health. The definition of public health that I mostly love is the one that says that public health is 50% policy, 25% diplomacy and consensus, and 25% science and documentation. Today, this communication pathway with the political leadership has opened. I would really like to see the people who are around the Prime Minister to open this pathway, communication channel. There are people currently in Greece who really suffer for this country and this public health. And the only thing they can do is merely write articles in newspapers and express their views. They are never invited as a body to participate in that. Even the committee should not be a committee of specialists on contagious diseases, but they should be a committee of public health. And the day after, what we must do so as not to find ourselves in the same situation, to be able to have a system that we will be decent in all levels, from the national to the local one, to have a feeling that there is this consensus, both political and scientific, on these hot topics. I agree on what you said about the vaccines. It is unacceptable what happens, that parents are convinced by some centers not to vaccinate their children. We have passed half a century speaking of the human rights of smokers, although it was obvious that tobacco companies would make us addicts, and that was a violation of our rights, but some would view it otherwise. So I conclude by saying that we have a lot of way ahead. It is important the way we handle far more difficult now, because today, when we emit contradictory messages, how many people should be at the bar, whatever guidelines continuously issued, which are not a continuation of the previous one, this causes both concern and indifference. That's why I say, reiterate, public health is not merely have the clinical knowledge. I believe and I hope that tomorrow we will get back this law. The law will retrieved. We will rethink public health in our country. And when we think of public health, we will be thinking of all and think that some people pay a far harsher price due to the social conditions of their lives. And unfortunately, this is not an information we have in our country. And unless we have this knowledge, we will never be able to put health and well-being at the center of our visions for our better Greece. Thank you.
Thank you very much, Mr. Chouros, for your intervention. It was deep, very substantial and essential. I will fully agree with you as regards public health in Greece. It's underestimated, even as a subject in universities at the regional level as well. Right now, we fortunately have an effort to create regional committees for public health. Now, as regards the general committee, we don't only have infectiologists, we also have epidemiologists and people who have worked in public health as well. Now, public health is our topic, and you spoke about vulnerable populations, and let me inform you that 50% of the people hospitalized in our hospitals in the Attica region are not vulnerable because of their health, but because of their economic situation, socially vulnerable. Thank you very much. Last but not least, we have Mr. Ilias Kyriopoulos, who is Fellow in Health Economics at the Department of Health Policy, London School of Economics and Political Science. His presence here is of absolute importance because we have the financial impact, economic impact of COVID-19 as well. Good afternoon. Thank you very much for your invitation. I have a presentation. I don't know if it is there. My presentation will be less about financial about the financial impact. It will mostly be about the issues that Mr. Chouros raised, and I will speak about the socioeconomic issues from this crisis. We have income issues, health market, education, everything has been influenced. This is the capital market index from the 90s until today. Projections for 2020 is the first year when the human capital index is below zero. what is this index? We have educational results and life expectancy as factors. In the last 30 years, this index has never been below zero. It's the first time we see it in red. We know that global economy will have a drop by 5%, a recession by 6 to 7%, and 40 to 50 million people will be below the poverty line because of the pandemic. And this is something that Mr. Chouros mentioned. I don't have data about Greece, unfortunately, but you can see the socioeconomic gradient in mortality. This has to do with social and economic ranking. We have males and females, males in green, females in brown. So the poorest regions are in the worst condition. The same goes for diagnosis. This is the equivalent of LD in the UK. Once again, both males and females living in poor regions ran 1.8% more risk for mortality. So the mortality rate is higher in poor areas. There is a trend, both in males and in females, even for coronavirus. This is a slide about inequalities in medical outcome and inequalities as regards coronavirus. This graph has been recently published. It's the Gini coefficient. It's about income inequalities. And it shows that after a pandemic, and the authors here have taken into consideration 5 or 6 pandemics in the last 20 years, it seems that this income inequality increases after the pandemics, and this increasing trend continues for more or less 5 years after the period of the crisis. So the income in the top 5 richest ranks of population is higher, and it is lower in the bottom 5 ranks. Once again, the same paper shows that those who were less educated get less work than those who are well educated. And there is a steady decrease in these figures of working people amongst the poor, even 5 years after the pandemic. Here you can see different countries. You can see the impact of the pandemic on labor market. This is the so-called segmentation of the labor market. In Greece, more or less 13% of workers had to stop working or work less because of the lockdown. The sectors that were affected are mainly those where people with lower wages work. In other words, the coronavirus has affected those who are not so well paid and not those who are more flexible in their working hours, those who are better paid, and those who can work despite the pandemic. In the more flexible sectors, people are better paid as well. That's what you see from the graph on the right. In other words, there is this segmentation, and there are two different trends in the labor market. I will close with some remarks on learning. This is the Institute of Financial Studies of UCL, and this is a study about new technologies, new forms of learning, and how they affected children during the coronavirus crisis. We saw that families in the top ranks, in the top financial ranks, had 30% more time spent in education than poorer families. And children in those families tend to have better access to a series of tools that are important for this type of learning. Finally, this is another study by McKinsey in the US. We see all these consequences that education had suffered from. We see that these consequences will affect education as a whole, and those who will be mostly affected in the US will be ethnic minorities and low-paid employees. This is important because we've already empirically shown that good education can improve the financial situation of a person. So educational inequalities might lead to social equalities in the long run. Finally, several experts were asked about how they see inequalities in relation to growth and human capital, education and health, in other words. 7 out of 10 said that the consequences will be long-term. They cannot say if the effect will be high or low, but they can say it will be long-term effects. Finally, this is my last slide. Vulnerable groups are those who are over 65 years of age, those with chronic disease, but also poorer people. Poorer people are more likely to get the disease, to die from the disease, to be marginalized because of a lack of access to education. And finally, there is also some literature about the long-term effects of inequalities, learning inequalities in the future. In other words, learning inequalities right now will have social effects in the future. This is something by Joseph Stiglitz and Christoforos Psaridis. They say that the pandemic inequality has a feedback loop. They actually say that the reduction of inequalities, it's not only an issue of politics. It's a basic strategy in the fight against the pandemic. Thank you very much. I hope I didn't take up much of your time. Well, you were very interesting, and you did not take up much of our time, Mr. Kyriopoulos. What you said about the feedback loop is very interesting. It's a destructive loop at this stage. And now we have a new type of racism, social and educational racism. We will see that a COVIDism. It's like ageism or sexism. Mr. Touros wants to say something on that.
I wanted to say that in relation to this vicious circle Mr. Kyriopoulos mentioned, and in relation to the various conspiracy theories, I consider it so exaggerated when all these outlandish conspiracy theories are developed about the big guys, the capital, the strong capital, and so forth. And we do not think that this unbridled capitalism has created so many inequalities with the exploitation, in so many words, that is the one generating diseases, pandemics, climatic environment, climatic changes, the huge population transfers, and so forth. I mean that we may get involved with scenario which are outlandish while it happens right now. There are activities that indeed are culprit for all these problems that makes us even more vulnerable. Yes, you're right. You're right. Thank you. And if only as many citizens as possible could listen to us. Is there any questions? Are there questions raised to the speakers of the roundtable or amongst us, or comments? I don't see from the chat room any questions raised. We have slightly exceeded the time, but everything was extremely interesting. So we are within the time allocated for the session. I warmly thank you all. They were all complimentary presentations. I really enjoyed them. I thank you all for your participation, and I wish all the best for all of us. Have a nice evening. Thank you, Mr. Rose. We thank all the speakers. It was an extremely interesting session. We have uploaded on our website this discussion, so anyone can follow this discussion and all the previous ones. Thank you. Now we'll proceed with the last session, and we'll be concluding our conference with this session on the subject of health expenditure, pharmaceutical and biomedical technology. Mr. Makis Papataxiarchis, the head of our relevant committee of our chamber, will be moderating, and excellent speakers who will be discussing the issues of expenditure of health and biomedical technology. Mr. Papataxiarchis, you have the floor first, and you introduce all the others. Good afternoon to all of you physically present and virtually connected. We had the last session of the HealthWorld 2020 that regards health expenditure in pharmaceutical and biomedical technology at large. We all know that this is a subject that it is at the core of any thought, need, agony, and contraposition, a juxtaposition with the political leadership. It has always been a huge major. So in this last table, we have excellent speakers and representatives of institutional agencies. They would be presenting the ways we intervene, the problems we have, and we'll try to draw some answers. I'll start with the fact that we also have with us Mr. Dimitris Philippou, the head of the EOF, that is the Hellenic Organization of Drugs through Internet. And I have next to me Mr. Olympios Papadimitriou, We also have Mr. Theodoros Trifon. Ms. Papadimitriou is head of SFE, Mr. Trifon, head of PEF. We also have with us Agata Yankovic and Mr. Gerasimos Livadas, who is the president of the Association of Medical and Biotechnological Products Companies Association, SAVE. Let me start by asking a first approach, a first introduction, first thoughts before raising the questions. We'll try to make it a bit interactive. So let us start with the head of EOF, that is the Hellenic Organization for Drugs. Honorable President, let me thank for this extremely honorary invitation. The presence of the state in such a unit is very important because, as you very well said, the expenditure is the main golden apple between the state and the industry. It would be useful to have with us the Deputy Minister, Minister of the Health of the Ministry of Health, Mr. Kondezamanis. Unfortunately, he cannot attend, so I'll make an effort in a way to replace him and express my thoughts and views on the subject, both in my capacity as President of EOF, but also as having the experience as head of the negotiation committee. In order for someone to follow my presentation, I have prepared some posts. The health expenditure and pharmaceutical and biomedical technology are decisive pillars in shaping the pharmaceutical policy. In the framework of the medical and pharmaceutical treatment, the policy, the health policy elaborations, the health policy politicians, elaborators, deal with many challenges. That is, how they will combine the accession, the easy access of patients to treatment services, but at the same time, how they could contain the pharmaceutical expenditure, which is of critical importance for the sustainability of the health system. So on one hand, we have the various patients with the treatments, and on the other hand, we have the economics of health. These must be combined in order to have sustainability. Between the various countries, we see important discrepancies with regard to the height of pharmaceutical expenditure. These are due to main parameters, the volume, the composition of pharmaceuticals, different distribution practices, but all these and each contribute to pharmaceutical expenditure. So it's extremely important to assess them. Regarding the impact of the various characteristics for containing pharmaceutical expenditure with regard to shaping those measures and the effects, we have not yet strong scientific and research data. Nevertheless, the continuous monitoring of all the applied rules and implemented regulations is important, so as to secure these two pillars. On one hand, that is access of the patients, and on the other hand, the sustainability of the system and the sustainability of the funding of the system. Drug policy has steady principles and values that must have the patient at the center and must aim at shaping a regulatory framework which should secure the following. The use of the treatment services must lead to the best possible result, especially of chronic patients who are more vulnerable. This can happen with the adoption of practices based on specific data and methodologies. On the other hand, the consumption of services must be governed by the principles of reciprocity and the rational use of the resources. And finally, effective communication and information of the citizens so as to be compliant to the treatment. This is of equal importance for a stable and credible pharmaceutical policy. Bearing in mind the international trends as shaped, the axis of priority are shaped as follows. First, securing equitable access of all citizens to the necessary, appropriate, and effective pharmaceutical treatment. That must be, as we said, at the center of pharmaceutical policy. Second, securing efficiency and economic sustainability, and this can be attained through the studies of studies with regard to the output assessment of the various methods, through the setting priorities when we use various state-of-the-art technology, that with the introduction of the negotiation procedure for the pay of new drugs, newly introduced, demonstrating our country as a center of excellence in the field of clinical trials, monitoring trials, and of course the use of mega data, which are currently collected and harnessed by the rapid introduction of new technologies. Therefore, this transformation with introduction of a new system was abhorred by the current pandemic. Therefore, when exploiting all that data, we can exploit the current data that have already been collected and draft and execute a health policy that will be based on reliable data. Finally, we should apply the national plan of clinical trials. Fourth, the creation of a stable framework for the operation and development of pharmaceutical market. This can be attained through the standing claim, the signature of an MOU between the state and all the involved parties and interests. This will secure stability in the market, will set the rules, and will help in approaching and attracting investments from international. Now, the support of the domestic pharmaceutical production, so as for it to become more extrovert, is another important axis of decisive importance. And finally, we must modernize and upgrade the institutional role of EOP to become the two major organizations and be adapted to the international models, offering modern services. Specific activities are already implemented towards these basic elements. In this brief period that I'm here and follow closely institutionally, either through the negotiation committee, the field of health, we see a shift, a mutation of the pharmaceutical policy towards an improvement, and this makes me very optimistic. Now, what are the actions, the basic elements? Is setting modern systems for the payment, the so-called managed entry agreements. The emphasis is placed in the intervention. The MOU between the Ministry of Health and the pharma industry is to be signed and will entail specific goals, obligations, and measures so as to have a stable framework in the market. All these are movements that will definitely rationalize public pharmaceutical expenditure and will facilitate the adoption of rational measures that will also boost the local demand. We must broaden also the incentives for R&D. This is an important part. E-prescription will also come to the hospitals. Thus, we will be collecting big data the diagnostic protocols have already proceeded. We set rules of prescription so as to limit expenditure, but also have a better clinical practice. There's a series of other interventions but what is definitely decisive is the interoperability of the systems. That is, how the systems will mutually read each other. It's something time-consuming, but it is in evolution. This will facilitate the direct control of prescription, so we'll have an additional criterion in order to assess how the economic financial expenditure and how the data collected is being used. For hospital drugs, special packaging will be determined to be separate from that offered to the general population. And finally, we aim at a timely identification of innovative therapies through the horizon scanning. And this will help in a more rational use of resources. In conclusion, let me mention that a lot of things already happen and they are precedented for our country, but there are also a lot of things that are left to be done. Unfortunately, the impasse in the field of health is huge, so there must be a close cooperation between the involved parties that already exists, and I'm optimistic that in the long term we will manage to all cooperate and shape an effective pharmaceutical policy. Thank you.
Let me thank the President of EOF for his introduction, and let me also thank him for the very simple fact that we were supposed to have Deputy Minister Mr. Kontozamanis with us today. He has to be in Thessaloniki, and Mr. Philippou replaced Mr. Kontozamanis. He's always a mild speaker and very constructive. Please don't use up more of the time that you have available, because we have more speakers to come. And expenditure is a very important issue that should come as a result of negotiations. We have the president of SFE. It's the Association of Pharmaceutical Companies of Greece. Thank you very much, Mr. Papadoxiarchis, for coordinating this discussion. In the last period, many unpleasant things have happened, and this is something that is ongoing as Greece has entered a continuous period of crisis, and the issues with pharmaceutical expenses are something that has an unprecedented rate of developments. We have new technologies that are being discovered at a galloping rate. We are here to deal with a system that will be self-destroyed in the future. It was programmed to be self-destroyed. Could you please move on with my slides? Okay. We all know how this type of expenditure has evolved in recent years. The reason why I'm showing this slide is the right part where you see hospital expenditure. In the first 3 years, we had a closed budget. We didn't have a closed budget, and the following years are with a closed budget. This is a picture that is self-explanatory. We have a system that is doomed to be self-destroyed. Now we are not in the economic crisis anymore, but we are in the COVID-19 crisis. In this period of the economic crisis, we had been spending less than any European country in health. And in 2019, we were at a point where pharmaceutical companies had to pay 37% of the public pharmaceutical expenditure, patients 13%, and the state paid all the rest. If you know maths, you can see here in this projection that if we continue like this, and what is this? To have this increase in expenditure at the same rate, at this rate, every year. This is 4.5% on an annual basis. If we do nothing, we will reach a point where the pharmaceutical sector will pay 110% of public expenditure. In other words, it will pay more for drugs than the state itself, which is supposed to be here to cover people who are insured with social insurance. I wouldn't like to do injustice to the current government, because it's the first time after so many years that the problems of the pharmaceutical companies have been dealt with with more dynamism. We can see that some legal acts have been issued in the last year that aim at improving the situation. Unfortunately, all the previous years, and unfortunately, in the period just before now, not much reform has been made. So the measures are mainly economic and have to do with the financing of vaccines, which is a measure that our industry had prepared many years ago. And the abolition of the introduction rebate for new drugs is something good, because we will have drugs that have never been available on the Greek market coming to Greece, finally coming to Greece. And then we have financing for some other important issues, but this is correlated with the clawback and the rebate issues. We've seen that off-label and generic drugs have been excluded. This is a blow on innovation. What type of economies, what type of streamlining of expenses is serviced with this measure? If a drug comes out in an unprotected market, many generic drugs and off-patent drugs will come out very soon. And you know how consumption works. When a drug is off patent, does this contribute to making savings? And let's admit that new drugs that give more therapeutical results are the ones that drive the expenses. And there is something that the Greek state has always been disregarded. It's the morbidity profile of our population. Anyway, as SFE, in cooperation with FK and Deloitte, we've made a study which concluded with 7 pillars of proposals, a pharmaceutical policy that will be sustainable for everybody. Apart from the clear and existing needs for financing, we have to see how the state can also intervene in other sectors which are important, because if we only speak about financing, we're just transposing the problem to the future. If we are talking about a good intervention, we should see our state accepting the co-responsibility as regards clawbacks. Checks on prescriptions, money for the uninsured, clear increase in the offsetting of investments with clawback. This is a very positive initiative. And finally, the introduction of an innovation fund. If this works, and if it has the right structure, it will make sure that we have innovative practices and treatments, and it will also lead to some annual readjustments of public expenditure in terms of drugs. Thank you very much, Mr. Papadimitriou, who represents SFE. This is something that he's been doing for many years. He can be consensual, speak about offsetting, make proposals for innovation funds, and put other issues on the table. For instance, the morbidity profile. You've allowed us to see the various aspects of the problem. You went beyond the institutional dimension. And now we have Mr. Trifonas, President of PEF, the Hellenic Association of Pharmaceutical Industry. He will now have the floor. Thank you.
Good afternoon to all. Thank you for the invitation. I will agree with practically everything that has been heard. This crisis has definitely demonstrated how important it is to cover patients with all the necessary medicines. And I would like to point out that both Greek companies and multinationals managed through the pandemic, and especially the critical quarter from March to June, to cover the Greek patient. This is very important because we managed to cover Greek patient far better than other countries of the European Union who were far more dependent on third country imports than Greece. This happens because Greece has a very strong productive basis. More than 3 million patients were covered by Greek production. And additionally, multinationals continue covering with no hinder the market, and this is important, must be said, as a part of the ongoing offer and contribution of this sector. And this is the first time after so many years that both the state and the audience, the society at large, realize that medicines is not just expenditure, it is an important additional added value. This is the first kind of remark, if you like. Now, there are a lot of issues at stake. I have a small presentation to make. I don't know whether you can see my slides. Can you see my slides? Not yet, but we will. In due course, says the moderator. We have a slight problem. Never mind. So I will go on without my presentation. I will be sending it shortly. So I was saying the following. It is clear that the day after bears a lot of dimensions. The first is that there will be sufficiency in medicines. In order for that, however, to happen, important problems of sub-funding and over-taxation must be solved. Sub-funding of public funds and over-taxation on all pharmaceutical companies, 70% if we take into consideration rebate clawbacks. And obviously, companies with big personnel have all other additional contributions. This, of course, cannot be solved overnight, nor can be solved in an environment of limited resources. So a lot of things have to happen at the same time. Everything has been said. The point is how quickly they will be implemented, both with regard to HTA assessment and negotiation on one hand, the protocols, therapeutical protocols, the e-prescription that hasn't been very effective, and the policy on the older and non-costly drugs. It is only thus may we be optimistic that we might be able to deal with the ever-exacerbated problem of pharmaceutical expenditure, which will be burdened with new therapies. There definitely has to be an innovation fund, and we'll see how it will be financed. So we need radical solutions. I also agree that reallocation is not a solution, but unfortunately, when we had this extremely distorted system, when we had only reduction of a fund, pharmaceutical budget, no one complained. No one said that we've got a distorted system because it was to the benefit of some companies that didn't bear the burden, had very little impact. Currently, however, the system is distorted for all, is erroneous for all. We're against the redistribution of the weight. We need radical solutions and some decisions to be made. Proposals have been made. The Pharmaceutical Expenditure Monitoring Committee should take a more active role on the subject. Thank you for the intervention. Something I would like to thank you is mainly for the fact that you also save time for the discussion, and second, because you have very crystal clear position, and the messages were very clear as well. Do you want to add something? Yes, I wanted to go to the second part. We don't speak of supporting the local production, but we speak of attraction of foreign investments. This is the second big chapter. A measure that was had 50 million euros that would be offset from investments with clawback. 1.8 million euros was rebates. This attracted a lot of investment programs from foreign companies, and the programs will exceed 200 million euros, perhaps more over the next year. So it is clear that there's a huge opportunity here, both through this program, but especially through the Next Generation Fund, to have Greek and foreign companies enhancing their investments in Greece for R&D. That will mean not solely sufficiency in medicines and better cooperation of Greek scientists in R&D and with foreign companies, but it will be also the field that may be the bigger multiplier for the whole industry, a broad production basis and with great multipliers. I'm glad because it's the first time that we have such a multiplier of domestic added value. Whoever invests will have some incentives and some benefits, and this is only positive. Thank you, Mr. Trifonos. Thank you because you also raise other parameters, very important, because the issues of discussion, expenditure, cost, budget, are a bit autistic. The fact that you introduced the opportunities for all in the Next Generation Fund is very positive and broadens our field of discussion. The next speaker is the head of the Pharmaceutical Companies Committee, the International Pharmaceutical Companies in Greece, and actually is the absolute expression of innovation in pharmaceutical field. So, the president of the Pharma Innovation Forum, Agata Jankovic, will take the floor. Thank you for being here.
Thank you. Thank you for a kind invitation. And as you said, I'm representing 25 research and development international pharmaceutical companies that provide patients with the treatments and therapies to save and improve lives. With this one, I would like to have my slides on. So, can you? Oh, okay. Thank you. So what is today the current challenges that we are facing in the pharmaceutical care? So we kind of group it into the three buckets, One, it is, by no means COVID-19. So how do we fight a pandemic? And our companies, research and development companies, are working really hard on their scientific innovation to bring the solution with emphasis on science and data-driven decisions. So the solution will be brought by the companies that I represented here. The second big bucket is the innovation revolutions. And I was very happy to hear it, our first speaker, Mr. Filippo, saying, that we need to broaden the incentive on research and development. Because yes, the innovation revolution is here and is now. An evolution is happening now with genetics, with precision medicine, with biologic treatments, and so on and so forth. And the last bucket is non-sustainable financing. I think we talk about the financing, so currently pharma access spending is a significant fiscal problem, but also some kind of a lack of policy priorities leads to sort of higher patient co-payment and low industry treatments and industry investments. So if we can go on and really substantiate it, what I said before, and put a little bit of a different spin what my predecessor have said, today, here it is 4 buckets of pharma budget. So basically the total pharma market, the retail market on the right-hand side, on the upper right-hand side, AOP1A, where are the elements of majority of oncology and a serious disease type of treatments, and public hospitals. What do we see here? We see that in where total pharma, the spending is about 2.5 billion, the industry is contributing about 2 billion. And if you move to the lower part, where it's LP1A and where it is a hospital, we're seeing that the pharma contribution is equal, if not higher, to the public spending there. So my question there is, what will happen if one of those industries will break the leg? Who will cover the gap? What will happen there? And I think it's a relevant question that we need to ask. Put a little bit of a different perspective into it. It's again the same 4 buckets, total pharma in upper left corner, the retail pharma market in the upper right corner, AOP1A, and the hospitals. Today, on average, for €1 that government is spending, industry is contributing 80 cents. For every euro, industry is chipping in 80 cents. Moving forward is in hospital segment, in LP1A, where I said before, there is mostly serious patient with serious diseases that they need a serious treatment, oncology, immunocompromised, autoimmune diseases, and so on and so forth. For every euro is at least €1 contributing by pharma, or in case of 1A, for every euro that government spent, the pharma is putting more than €1, up to €1.5, in order that patients has access to medicine. So the question is another one here, it is, who is setting the budget? Because if the pharma is contributing more than the pharma spending. Going further on is, what has happened in the year of 2015 to 2018? In by EMA, there was 170 new medicine approved. In Greece, out of 170, only 65 made it to the Greek environment. Now, we also, what makes me really happy, so listening to the first speaker, it was about that we need to, the public policy and the policy needs to focus to increase and secure access to the patients for those medicines. So that said, the need is there. It's not that the patients here, they don't have a need. The need is there. We need to secure the access to those new innovative treatments. Let me move the slide. Yeah. And I'm closing it up and wrapping it up. So the change, what does it require a change? The change requires, the political will, usually. It requires, the stakeholders or the people, and it requires the effort to put the right mechanisms in place. And before I go to the final topic of that one, let me share a little bit of a personal story. About 3 weeks ago, my father had a light stroke. Thanks to the speed, to the new solution, to the innovation, to really the decision made based on data and analysis and based on really excellent connectivity in our country, In few hours, he was operated, and 5 days later, he was out of the hospital. That's all because of, the great innovation was put into place, the great solution was put into place, the speed and the fast solution. Unfortunately, his older sister, few years earlier, was not that lucky. And that is what all innovation is all about, ladies and gentlemen. So saying that, I think we need to really look at, more of a structural reforms and what are the solutions, what will be the health few years from now. I think we have already observed and seen with my predecessor as well there, and also current moves into right direction by creating a prevention budget. What does it mean, prevention budget? Prevention budget means, the disease will never happen. So it is the right solution, is the right management of public spending. There are a lot of other elements that has been there, but I will mention another one. It's also focused on prevention, but also on behavioral change by different initiative, by education of the young generations, and by the tobacco law. However, I think we need to also look at what do we really need to go further on. And one of the things is that we need much faster solution. We need a faster decision making in terms of negotiation, in terms of reimbursement, in terms of how we will make access to the new treatments and the new products. We will need to have, and we heard also from the speaker, we have to upgrade the current institutions and current systems. Lastly, what I will say is focus on the structural reforms, not on a crisis-based initiatives that is really short-term solution, but not provide a longer-term solution and sustainability. And the last one, I would suggest we need to have a roadmap for a policy change so that state would pay less, that industry will be sustainable in the market, patient will pay less of a co-payment with a better outcome. And what this roadmap could look like. So some of the elements we have heard already before, which really, so it's really rewarding to see that one. But in the next 3 years, with all of those elements, we can achieve sustainable pharma market. Stable and predictable pricing, transparent and effective HTA process based on the real world evidence, the data, negotiation and reimbursement, electronic medical files, so which will allow prescription monitoring and also link to the spending with the patient of outcome. I think that's another very important element. Empowerment of let's have a clinical and biomedical research, and most importantly, real-world evidence. Greece, with the currently great data, I think we have great opportunity to have a center of excellence on real-world evidence data. So with this one, I think I'm over with one time, but thank you very much for the invitation.
Thank you very much, Agatha. Allow me to speak still in English, just to say that it's so important to have your visionary and clear positioning on how and what innovation faces in Greece, obstacles, and let's say overall all the challenges, and also that giving another perspective, more strategic, speaking about the roadmap on top of the reforms and the structural reforms that we have to make, and also by questioning what will be the system and how we want it funded within the next years. So thank you so much. Ευχαριστώ πάρα πολύ την Αγκάτα για το γεγονός ότι παρουσίασε τα προβλήματα της καινοτομίας στην φαρμακευτική βιομηχανία με ένα απόλυτο τρόπο και το τι αυτή αντιμετωπίζει στην Ελλάδα.
Industry in an absolute way, and how it is those problems appear in Greece, and also making specific proposals. But the field of medicine doesn't only have the medicine, and therefore I'm very glad for the fact that Gerasimus Livadas, who is the chairman of the Medical and Biotechnological Products Companies Association, SAVE, is here so as to give another dimension, the full dimension. Thank you. Thank you. I also thank the Hellenic American Chamber of Commerce for this very honorary invitation. Let me start with a comment of the representative of the state who presented in detail the ministry's policy regarding pharmaceuticals. Unfortunately, he said nothing with regard to biotechnological products, despite the fact that the title of this session clearly states that we speak of the cost and health expenditure in both pharmaceutical and biomedical technology expenditure. So this is not, however, personal comment to Mr. Filippo. It's just a statement. There is a lack of policy with regard to biotechnological products. There is a policy vis-à-vis medicines, but not vis-à-vis the non-medical products, pharmaceutical products. There's a general mentality shaped many years ago, which does not give the appropriate importance to technological product. And this we see it from the results. There is no assessment whatsoever of medical technology. And therefore, and this is a proposal that were made to the ministry in order to jointly promote some programs. Health cost at large is a limited sum, specific, and actually it's not that big. Greece has a percentage of its GDP earmarked for health, and this can be remarkable because 8% of the GDP is very close to the average of civilized country. But if this is translated in euros, we are definitely lower than other countries. Therefore, we have a big need to clarify what are the real needs and how they can be covered. The ministry's policy slightly ignores the difference between real need with demand. This demand might be triggered and fictitious if you think that Greece is the country with the biggest number of physicians per capita, not only in Europe, but all over the world. And there's a huge number of pharmacists and drugstores operating in Greece. Therefore, the one who prescribes and the other who supplies the public system and patients with medicines can slightly differentiate the real need and create a so-called demand, which perhaps does not really represent the reality. This is something that the ministry should think, because the expenditure in drugs is 26.5%, while similarly the respective European countries have 16%. Additionally, as far as our field is concerned, with biotechnological products, we're very limited. We have a mere 30% of the drugs expenditure. And if we bear in mind that there are devices such as the big imaging devices for XTs, the mammography devices, the magnetic resonance imaging, there's a plethora of all that. Again, we're champions there because those devices are to be found in all hospitals, but also in the private sector. The efficiency, however, of those devices is not in relation to their number, because many of those devices, because they are extremely expensive, they are operated on 2 or 3 shifts abroad, while in Greece, hospitals, for instance, only operate the device in one 8-hour shift. So another policy is demanded here that should be dealt with broadly in the ministry and not on a case-by-case basis. And the registry of those devices should be made, because that stock taking would greatly help so as to see what are the real needs and create a program for the future. And more broadly, the issue of biotechnology and devices in our field is not only that governed by this mentality that this field is not important. We also have a lot of problems that might also be solved, because there are a lot of hospitals There are hospitals, if you like, that cannot cover the needs with the biotechnological problems on the basis of the money they receive. They do not ask for additional funds. Therefore, the ministry cannot see this demand for additional funds. And the way they deal the problem is to ask from the companies to have the material delivered, non-invoiced, therefore with no financial demand, merely with a bill of lading, and then expect 6 or 8 months for extraordinary budget for that material to be paid. This, one might say, is inconceivable, because it is also illegal as far as companies are concerned. We do not issue invoices. This is illegal per se. And another major issue that we share with the field of medicines is the clawback, which operates as with the others. This is how much money we've got, this is how much we can give you, so we can't try to assess what is the real demand for that material. Thank you.
Thank you very much for keeping to your time. And secondly, let me tell you that we have hundreds of pods following us right now, so your message is there. And we've seen that in the past, you and Mr. Liakopoulos have always been very sensitive to these issues. Such an important and sensitive sector has a weakness in negotiating and speaking with each other. We have some historical responsibilities, and this is not up to the standard. It's terrible that you cannot speak with each other from an institutional point of view in order to be heard, in order to take answers and bring things forward. I have a series of questions. President of EOF, let me start with you. Here, I have a question for you as the chairman of the negotiations committee. Can you hear me? Yes, thank you. So, please, you have 3 brief questions. Please take your pencil and note them down. Negotiations so far, we haven't got a number, a figure. We don't know the result of negotiations so far. What does it mean for the budgets? Secondly, a colleague of ours is asking if there is a list, or if a list is going to be published as regards the companies that will come for negotiations. And third question, the law allows you to form 2 subcommittees in order to run things more quickly. You haven't done it. Are you going to do it? These are the 3 questions. Okay, let me answer to Mr. Livadas first. Let me make a remark, because some of your concerns are meaningful, but there are also some explanations for them. Expenditure for drugs is not in a similar situation like that for medical devices. Medical devices have been left behind because we have a heterogeneous group. We have 160,000 different codes in our country. We started many years ago, and this effort is going to be completed very soon. We want to have a registry for these devices. In order to evaluate something, you have to register it. And this is something that the European Union has not managed to do either. So your complaint that from an institutional point of view you are not well dealt, well, please consider that medical devices are treated differently than drugs on a European Union level. In Greece, we have legislation for approving drugs. In medical devices, we don't have a similar approval, let's say, mechanism. We have a notification mechanism. We don't have investments in medical devices in Greece. As far as I know, we don't have production or certification companies. This is an industry, a sector that is still very young. And until this area becomes more mature, you will continue having the problems. First of all, we have to complete complete the whole registration process. It is true that you have a big share in the spending, but some things have to happen first. Now, negotiations. They have a critical role to play, and I'm glad to be a member of this committee. We had decided to issue a press release in order to inform people about what is going on. We didn't manage to do it because we were not ready at the 6 months period that we had set as a goal. Now, until now, 240 new codes have been promoted and 4 negotiations for categories have been completed. This committee is only there and has been really working for 7 months, and taking into consideration that nothing had happened in the past before our committee, I think this committee has done a lot. The works of this committee were very successful, in other words. And there was this list of categories for negotiations that the ministry was supposed to give us. We didn't have it, and by the end of the year, I hope we will have them. And the next categories are those that are very heavy for the budget of AOP and of the state. Treatments, multiple sclerosis, melanoma, all the things that the ministry has already announced. And then there are some other categories you can find on the same list. Now, the 2 subcommittees, we have this possibility and we will use it. For the moment, our committee is only dealing with negotiations, as you know. We have to first make sure that this committee has been set up properly and is operating properly. Its role has not been fully developed in the past. Now we have to look at the loose ends. We have to see how we can change the legal framework in order for the role of this committee to be to be improved. As we are now trying to see how we can improve the committee, we're in this process. We actually decided first to make sure that these parameters are set and then move on to the second set of priorities. And I'm sure that nobody has accused us of delays, but rather for the opposite.
Yesterday, in my introductory speech, I made a juxtaposition of the effectiveness of negotiation committee with that of the HTA committee. You don't have to reply on that. It's something that has been judged by history. It's obvious. And this fully gives you right justification. I would like to have a second statement from the president of SFE, the Pharmaceutical Company Association. I apologize, but the head of EOF managed to avoid a quantitative assessment from eventual benefits of such a negotiation. So if it's hard enough, I will make a more generic question. Since we've heard the minister yesterday proclaiming that clawback will be reduced this year in relation to 2019, in your broader role and your capacity as head of EOF and head of the negotiation committee, do you have a feeling, do you have a grasp on how much this reduction of clawback can be? And then I will make any statement you like. You just give me something more precise. Well, listen, this is a dynamic process. Our goal is that we want it to be reduced. Yes, that's what we said from the beginning. We must first rationalize the expenditure, reduce clawback. It is unjust. No one considers that this is a just measure, especially the way it has been implemented, in order, in due course, to view the next things, which is innovation, eventual increase of pharmaceutical expenditure, and so forth. Now, how much this reduction will be, I cannot say. It will be reduced, but I don't know. Listen, not only at the level of negotiation, but also at the level of ministry, moves have been made, which was your standing claim. For instance, the exclusion of vaccines from the pharmaceutical expenditure. You are far better in calculations than me, and if, according to estimates, we have a clawback of 945 million euros, according to the data of the first semester. Am I right, Mr. Papadimitriou? If we take away the vaccines, if we take away the negotiations that have already concluded with the prices, and if we co-compute the investment clawback that has been proclaimed by the minister, then I consider that that would be an important reduction. Well, as far as figures are concerned, I keep my reservations. Allow me to do so. Well, thank you. Well, yes. Well, on one hand, I cannot resist the temptation since we have you with us. On the other hand, I did not expect much more clarity from your side. But anyway, if this statement is materialized, it will be something important. What I wanted to say was the following. We have been discussing with various governments on structural changes, prescription protocols, filters, and so forth. On one hand, there is an all-time delay in integrating all this, and on the other hand, I have not personally understood what could be a possible impact of all these reform movements in the evolution of expenditure, if there is such impact. So I really am frugal in my expectations, because you have no element assuring us on the outset. A second point is the following. If I'm not mistaken, there's a term in English called ownership. In Greek, we might say the feeling of ownership. I'm afraid, therefore, that at this point, we operate, along with Mr. Livadas, the biotechnological device, we operate a system for which the only ones that have a feeling of ownership about the expenditure, it's ourselves. The pharmacists, or if you like, let's say the physicians, start from there, have no feeling of ownership of that expenditure. They never did. No, let me say something else. For me, ownership is that I use something as if it were my own. That is, I care how well it will perform, how will I control it, how will I curtail it, how will I manage it appropriately. So physicians have never had that kind of ownership for the mere reason because they were never accountable for the cost of the pharmaceutical expenditure. Pharmacists, on the other hand, definitely have no ownership because the bigger the expenditure, since we've got the ceiling, not them, the bigger the profit for them. Same applies for the wholesalers. I'm afraid that not even the government has an ownership of that because they have just thrown a number on the table and they know that will be it. That's the ceiling. That's it. That's what we'll pay. You find a way. So it's only us who have the agony and the stress, whether figures will be all right this year, whether what we have as obligation will cover the patients. And we have an AOP that cannot collect a lot of the desired and of the overdues. So all the moves for enhancement of financing are positive, but we must live with the idea that health expenditure will be increasing as time goes by. They will be increasing because, unfortunately, morbidity increases, life expectancy prolongs, and we're a country with an ever-aging country. We have not enough births, we have more retired persons. Unless we all die of coronavirus and the problem will solved, I don't know. So I hope we find reform moves as soon as possible, that we will share, that will disseminate this feeling of ownership to more than one. Thank you. I warmly thank you.
Thank you very much, Mr. Papadimitriou. Sometimes simplification goes deeper. Thank you very much. Yesterday, we spoke about the new declarations of the Prime Minister in the Economist Conference that clawback this year will be different from last year's. So I would like to hear your statement on that, Mr. Trifon. Well, we all agree that this is a very difficult equation because spending will keep increasing. The new drugs will be very expensive, and an evaluation and the negotiation has to happen. But apart from that, we need to set the basic principles. First of all, each party has to pay its own share. Right now, the pharma industry is paying for categories that are not for our purse. We have people who are uninsured. From 90 million, we have 270 million as expenditure, and this is something that should go to the public structures, and this hasn't happened. And of course, we pay clawbacks on retail price. Is that possible? So the industry has to pay its own share, and the total distribution will have to be negotiated on the basis of several targets. Many things have to happen together, and of course, financial co-responsibility of the government is important. This is what we are aiming at. We want something measurable, and the negotiation committee is doing that exactly. This is what the state wants to say. I'm saving this money, and this is how I'll do it. And my view is that the state should have a co-responsibility. Finally, drugs are not only spending, are not only expenditure. It's a product that promotes innovation. It has a contribution to the GDP, and this has to be part of the equation. The higher our GDP, the more social expenditure for drugs and pensions we can have. You were very clear and brief. Thank you very much.
My predecessor have said, but the only one thing I will say it, as I said, if we will to make change, we need to have political will, we'll need to have stakeholders there, and we need to have an effort put in place. I will draw only one attention, or two things I want to mention it. If we really want to go and really committed to do something, then we should put a clear target. What should be a target of clawback this year? I know it is hard, I know it is difficult, but we should put it, the numbers, or we commit commit into it what should be the clawback level of this year. Secondly, what I only want to say, I'm really concerned on the channel of hospital and 1A. These are the patients with the serious diseases, and as we said before, when is the budget in, for instance, 1A channel 85 and the consumption is nearly 200 million, I think, we are running a big fiscal risk there. Okay? With this one, I'm not going to go and repeat anything further that has been said by my predecessor, but I think we need to go, it should be set the target where we want to end.
Clear as well. And thanks for pointing out in specific therapeutic areas that for €1 from the state is more than €1 from the industry, like you said in 1A.
Correct.
Thank you so much.
Correct.
And this is innovation as well, the Innovation Fund.
The question is, the only one thing, the question is, if today is a new innovative treatment that any of the company, let's say there is a new Alzheimer product, how will that product make it, to the Greek market?
Yeah, fair question to all. Κύριε Λιβαδά, θα ήθελα να ακούσω ένα δεύτερο statement από εσάς.
Mr. Livada, I would like to have a second statement from you. There has been an intervention of the ELF president, so I would like to have your views. I would like to answer to Mr. Philippou. I mentioned a mentality. This has nothing to do with whether we have a cadastre or not, a registry or not. We support that and we wanted it to have established, but we are lagging still behind. But the issue of mentality, I will use a very topical example having to do with the COVID-19. When the pandemic had the outburst of the pandemic, the ministry had a public interest for the procurement of some machinery, some equipments. But when they got certain on what they needed, they went to the companies and said, bring along the material because the call for tender may be late, but you must be ready. When the procedure did take place in a very hasty manner, the result was the COVID was already lagging behind. You know what the result was? The result was that those companies that staged the war to secure the contracts, to secure the production, at the end of the day had no signed contracts and cannot deliver because COVID at the time had gone by. So these machines lag behind. They are found in the storage rooms of the competing companies of the time. This is an indication of what is the mentality vis-à-vis the biotechnical products. Thank you. Oh, thank you for the example as well. Although business-wise, under these conditions, one would expect or would hope for the coronavirus not to be over. I know we all hope that it is over. So, Mr. President, giving to you the floor for a final comment. I'd like to say that it's extremely important that this discussion has taken place. I would be very glad if you were able to clarify or perhaps give us another piece of news. And I give the closure to the state and you. For me, keeping for myself the final greetings. Thank you, Mr. Papataxiarchis. I will be very brief. First of all, let me thank you for the cooperation we've had these 7 months. I find myself as head of the ELF, and I speak of my institutional role because we are at the same side of the table. We received a condition that was difficult. 10 years of crisis with some procedures not operating. Within 7 months, we managed a lot. We activated mechanisms at the level of ELF. A lot has changed. Processes have been accelerated. We help the innovative therapies to be introduced. It is obvious that problems which have been chronic, unfortunately, cannot be solved overnight. There are no magic recipes. I consider, however, that we are at a good path. We will pursue. We do have the knowledge of what should be done, how the Greek pharmaceutical company and the biotechnological market must enter a modern environment, and I consider that we will pursue all our interventions so as both for the clawback to be reduced, the assessment to acquire the role, the appropriate role, to complete all the interventions for the biotechnology products, and I'm certain that we maintain the current cooperation. There is a political will that from 2021 onwards, when we will be living more intensely and better understand the outcome of the 2020 interventions, we will have ahead of us a radically different environment in the field of health. Thank you. Thank you for the madness, the decency and productivity and whatever you express, but I would mostly like also to thank all the friends and colleagues and chairmen, starting with Thodoros Trifonas and Olympios Papadimitriou, Agata Yakovich, and Vasilis Livadas and Gerasimus Livadas for the fact that at a very dire circumstances and under their leadership and having served with them, I must say, they have managed something that we haven't assessed. Under the current circumstances, they have all managed to radically change the picture and how a whole society deals with the field of medicines, of biotechnological products. Remember slightly how things were 1 year ago, how the image of our field is currently, the daily fight they stage for the employees, for the sustainability of their companies, for the predictability of the leadership of this landscape. I thank them and acknowledge their leadership. And it is my opportunity to proceed in closing the conference, and I do that for this 2 days conference. Traditionally, this is the biggest health conference of the year, and this was a huge challenge for us. This was a successful way. It's a way that tried to demonstrate the before, during, and after COVID era elements. It's the time that things come in an unprecedented way, and one must be ready to make a distinction between the urgency and the importance. And if what happens is urgent and has a stable and constant character, then it must be dealt with as significant because it regards human life. We experience huge challenges, economic, health, life issues. At the same time, we are obliged to speak of the day after of the Greek citizen or the Greek patient. I warmly thank you all for the fact that we did it in a scientific way, with a great seriousness, with great sense of responsibility, for the fact that in dire times, domestic pharmaceutical industry, all factors show the better self. We try to trace the policy of the next year or the next years, or discuss about them. Something that must be demonstrated, there can be no dogmatism. We must be flexible, and foremost that all reforms, those we have and those that come, will have a cost that we must assume with a feeling of responsibility, with a feeling of ownership, as the Livadasa said beforehand, Mr. Papadimitriou said beforehand, because we deal with the health and the future of the Greek citizen. I warmly thank the Hellenic American Chamber of Commerce for being the great feat, for being the most reliable pole for policy production. I also warmly thank Theodoris Liakopoulos for the fact that he was the mind and strength for all that, Professor Kyriopoulos, and of course, let me thank Ilias Spirtiounas as Secretary General and Executive Director, and the President Nikos Bakatselos, and representing all those who work the back office, Vula, Georgia, and all the others. God bless you, and let us all find ourselves in full health discussing on such important matters. Thank you. Have a nice evening.